national and international faculties, delegates, and ladies and gentlemen. Today is the second day of our NOS UROCON, and our first session is on BEP and lower urinary tract symptoms. So I'd like to request the chairpersons of this session to please come forward on the stage and chair the session. Professor Bharat Bahadur Bhandari, Professor Uttam Kumar Sharma, Professor Srinath Chandrasekhara, and Professor Rajiv TP. Thank you, chairpersons. Now, without further delay, I would like to request our first speaker to come on the dais, Dr. Anand Tankesar, on his topic, Advances in BPH. And the time allocated for the speakers is 12 minutes, and we'll have questions at the end of the session. Thank you.
Very good morning, everybody. As usual, for the second day of the conference, you are welcome here. It seems that my co-chairs are not around here. Must be enjoying Sarangut trip today. I would like to request Dr. Ananda Kumar Dhanasekaran. He is consultant urological surgeon, Sandwell and West Birmingham Hospital, NUH Trust, City Hospital, Birmingham, UK. He has got a specialty focus on mist and stone disease. He has joined NIH in 2015 to introduce NICE recommendation treatment for benign urological conditions, pioneer urolift, that is prostatic urethral lift procedure at the Trust in 2018. Team was first in UK to perform urolift under complete local anesthesia without sedation and help establish SWBH Trust as a recognized urolift training center. He has got expertise in efficient patient pathways and innovative treatment, reducing hospital stay. Dr. Ananda Kumar, please, the floor is yours.
Thank you, chairpersons. Slide, please. So today, for the past one day, we have seen various subspecialties, various changes happening, and updates, etc. In this particular session, since it is focusing on the male lower urinary tract symptoms, I'm going to summarize what all the advances happened so that it will be a quick summary of advances in the BPH and male LUTS care. So the modern urological paradigm is based upon 2024 and 2025 guidelines. We'll discuss EA diagnostics. We will discuss the metabolic links and the patient care. The previous stepladder approach for the men with overactive bladder is now removed. For example, previously we used to say that let the patient have behavioral treatment maybe for 4 to 6 weeks, and then pharmacological treatment like alpha blockers or anticholinergics, and then advanced treatment like beta agonist and surgical interventions. Now, this behavioral treatment, pharmacological treatment procedures are considered at the same time so that it's more of a shared decision making rather than a step ladder approach. For overactive bladder, as we know, the main thing is to start with non-invasive foundation treatment like fluid management, avoiding the irritants, physical management like pelvic floor exercise, metabolic management like obesity and diabetes management, pharmacologic managements like beta agonist and antimuscarinics, and finally ending up in the minimally invasive procedures like Botox, sacral neural modulation, and tibial nerve stimulation. If you come to BPH, now the concept has grown that it is not just a prostate problem, it's more of a systemic metabolic problem like diabetes, hypercholesterol, hypertension, etc. So there is a good amount of input from brain, like increased sympathetic tone, increased systemic tone, smooth muscle contraction. There is a now established link between excessive abdominal fat, inflammation, insulin, and resistance to the insulin in the peripheral. Pancreas, which results in hyperinsulinemia, and various growth factors also comes into play. So men who have a sedentary type of lifestyle where they need to sit more than 7 hours a day are more prone for BPH in the longer term. Skeletal muscle, previously considered as an important locomotor organ or later something like a muscle building, is now considered as an endocrine organ. The myokine mechanism is now established to have direct influence on a man's prostatic health. So good amount of aerobic and resistance exercise resulting in myokines and various markers like irisin, interleukin-6, brain-derived neurofactors, myostatin reduced results in good improvement of the chronic inflammation and promotion of autophagy resulting in good prostatic health. Coming to surgery, yesterday we discussed quite in detail a complete BPH workshop session on all the minimally invasive methods like UroLift, PAE, Resume, etc. So just to compare the whole beam enucleation and TURP, whole beam is now well established for prostates maybe more than 80 or 100 cc, and it results in less hemoglobin loss compared to the gold standard TURP. The operative time is large, but if you compare the amount of tissue extracted in that operative time, it is a very efficient procedure. And the stay is now become much more shorter because of laser being good hemostatic. Patients in our institutes, they are all discharged on the same day with a catheter, and catheter will be removed in a day or two as an outpatient visit. So the hospital stay is slowly getting shorter and statistically significant compared to the longer stay of TURP. It definitely offers also superior perioperative mobility and efficacy in 3 months' time. Coming to the PSA, we are moving beyond the PSA into a multimodal precision in diagnosing a possible prostate cancer. So apart from the simple PSA, family history, PSA density, advanced imaging like MRI radiodynamics and genomic molecules are coming into play. PSA is good in sensitivity, but specificity is very low, resulting in unnecessary overdiagnosis of low-risk disease. Artificial intelligence, yesterday also I did a full talk on artificial intelligence in urology. It reduces the variability in pathology. To err is human, they say. So it's very easy for a human eye to miss small amount of Gleason score or sometime even a high-risk Gleason score. While the AI reduces the variability and gives a very uniform output, and efficiency of finding low-risk disease and not intervening and keeping them in active surveillance can be done with more confidence. The AI also plays the equal role in radiodynamics, where it helps in extracting the texture and heterogeneity which is not visible to the eye. So the whole MRI can be interpreted in much better way, and as our sensitivity improves, as our predicting tumor aggression non-invasively improves, it improves the patient's overall pathway. Biparametric MRI is now well established in most of the countries, but are we able to eliminate contrast completely, still maintaining the good sensitivity and specificity? Compared to multiparametric, the biparametric acquisition time is only 7 to 15 minutes. It generates more revenue because we're able to use the system more effectively, and there is no risk for gadolinium-related contrast side effects, and very good for patients with poor EGFR or renal function. It is definitely established as non-inferior for screening purposes. Multiparametric MRI can be used for specific situations like post-radiation recurrence, and dynamic contrast enhancement can be used to see the recurrences in a treated tissue. Now, the whole trajectory of the urological diagnostics in the past from, say, PSA, digital rectal examination, blind systematic biopsy, has evolved to become based on more of risk calculators and multiparametric MRI and fusion biopsies. And in the future, with more biomarkers and biparametric MRI with AI analysis can give you a literal virtual biopsy where you can get almost tissue equivalent outcome just by using the AA and radiodynamics, and patients can be spared from biopsy, which already happens in renal cancer, for example. So the clinical takeaways in the advancements in urology are improvement in OAB strategy, shared decision making, abandoning the step ladder approach, systemic disease, systemic syndromic approach like myokine prescription, making the men to be more active to avoid prostatic symptoms, surgical selection for minimally invasive treatment, screening efficiency by using AA, and AA integration in histology are the main things we are looking forward in the present and in the next few years. So the whole presentation was taken from AUA 2024 guidelines, Mayo Clinic publications, Medicina, Journal of Clinical Medicine, and AUA News. Thank you.
Dr. Anand, it's a nice overall view. What is today, what was yesterday, what is today, and what will happen tomorrow was already described. I'm really wonder about this skeletal muscles is a new endocrine things, you know, that I think we'll discuss it later. I would like to
I would like to invite Dr. Deepak Thakur to present his presentation through FLEP made simple a practical video guide to thulium fiber laser inoculation.
Good morning, chairpersons and colleagues. I am given the topic of thulium fiber laser enucleation of the prostate, a practical video guideline to TFL. I have nothing to disclose. So laser nucleation process requires some learning curve, and this learning curve can be achieved via two approaches. That can be individual or mentored. If you have mentored approach, that is well and good. If not, you can continue without mentoring also. But it definitely required a definite learning process that needs commitment from you and repetition. Not that you do one case today and next case after 1 month. You have to do cases frequently. And of course, if you have preceptor, that is good. And you have to avoid your ego, and you have to select your cases properly during the initial days. It is established that HULEP can be learned in less than 50 cases. At the same time, THULWEP can be learned in less than 20 cases. So here I am presenting a case of a 72-year-old male who had lower urinary tract symptoms and BP, and he was under medication for the last 3 years. He developed refractory urinary retention and was on polyurethral catheter for the last 2 weeks. He was hypertensive. He did not have any intervention in the past. His IPS score was 28, and per abdominal ultrasound showed 64 grams of prostate with 1.2 centimeter of IBP. His RFT and PSA level were within normal limit, and urine culture was sterile. So we decided to go for THULEP. And these are our gadgets, laser setting. And the basic steps for the THULEP, what I follow is omega incision. If there is median lobe enucleation, commissural release, lateral lobe enucleations, hemostasis, and morcellation. So this is the video of the same case. Preliminary cystoscopy is being done. There are enlarged lateral lobes with some median lobe without much bladder changes. The omega incision is being marked. Here we went 3-lobe enucleation technique. Now we are giving a 5 o'clock incision that is extended from the bladder neck to base of this omega. And here the median lobe is in enucleation process. We use laser energy as well as some manual traction to enucleate. Another incision at 7 o'clock position from the bladder neck to base of the omega. You can notice some charm effect of TFL. We are still with median lobe. There are some bleeders which have to be coagulated at the same time. And this TFL has excellent coagulation property. There is tendency to go subtriagonally at the neck level, so we work closely here. Now the median lobe has been enucleated. You can leave it as it is, or you can detach completely, depending upon your choice. Once you clear median lobe, you have enough space to work. Now the anterior commissure has been released, and it will be connected to the distal ends of the omega on both sides to enucleate lateral lobe. Here we are enucleating the left-sided lateral lobe. The left lateral lobe has been enucleated as well. Now we are left with the right lateral lobes. Now the right lateral valve is also free. And before we proceed to morcellation, we should achieve adequate hemostasis. Otherwise, it will be difficult during morcellation, and there will be chances of injury to bladder mucosa. So now the morcellation in progress. After the procedure, this patient was catheterized with 22 French catheter and started an irrigation with normal saline. There was no event postoperatively, so catheter was removed on second postoperative day, and the patient was discharged to follow up with histopathological examination report. So my take-home message is THULEP is an effective and safe procedure for patient with BEP requiring minimal invasive surgery. And even you don't have mentor, it can be learned, but you need dedication and case selection. Thank you.
Thank you, Professor Deepak Thakur. Question answer will be at the end of this session.
Thank you,
I would
sir.
like, sorry? I would like to invite Dr. Bipendra Dhosh Rai. He is talking on demystifying urinary incontinence after laser prostatic surgery. Dr. Dipendra.
So everyone, hope you enjoyed your yesterday's session. So this is more of a theoretical aspects of surgery, where we'll just dissect the causes of incontinence. So why laser prostatectomy? It has already been highlighted by Dr. Anand, so I won't be talking on it. But if you see the picture on the left, this basically depicts what happens in HOLEP and what happens in TURP. Issues has already been highlighted by Dr. Deepak, but one of the main holding facts in HOLEP has always been the incontinence. And the high rate of incontinence reported in HOLEP is what holds the urologist to take up HOLEP and do the surgery repeatedly. But one of the most important thing in all the articles is that most of them recover. And the long-term results in incontinence is similar to what has classically done with TURP. So let's dive into the details of anatomy. The classical teaching of having a two sphincter at the bladder neck and one at the rhabdoid sphincter is not true. There are various components in holding of continence. The mucosal coaptation is very important. The lysosphincter is being talked about more often in laser prostate surgeries than most other sphincters. And pelvic floor muscles are very important. The proximal bladder sphincter is not the origin from bladder muscle itself, but it's the thickening of the lysosphincter that forms the proximal bladder neck. So what happens in BEP? One of the things when we are taught to start TURP is never go beyond the veru. But what really happens when prostate enlarges? If you see the figure, the prostatic apex starts to go beyond the veru montanum and tends to thin out the external sphincter. And the studies have shown that as much as 40% of the functional urethral length is ultimately covered by the enlarged prostate, increasing with the size of prostatic enlargement. So this portion is the distal lysosphincter, which is thought to be very important for continence in TURP. That's why we were told to never go beyond veru. But if it don't go beyond veru, the apical tissues, which is the most obstructing part of the prostate, will remain, and your outcome will not be effective. So, when a TURP or any procedures are done for prostate, there's a loss of this portion of lysosphincter, which increases the chances of incontinence. So what causes incontinence? What we thought is the rhabdosphincter injury, which is rare in HOLEP, but can occur. If you see the picture on the right is the through flip that I performed. This was a 100-gram prostate, and this is the end result. You see the mucosal ring is maintained, But this patient on removal of the catheter was totally incontinent for 24 hours. We had SUI for the first 2 weeks, but ultimately recovered at 3 months. So do we really know why incontinence occurs? And we know that not the classical teaching of the rhabdoid sphincter, the bladder neck and distal rhabdoid sphincter maintaining continence is not true. Because even with bladder neck injuries in the cases with pelvic fracture urethral distraction defect, 50% of these patients are still continent following that. So there has to be some other components in incontinence. Mucosal coaptation and integrity is very important, but as we see, even the visual guide to confirming the presence of mucosal coaptation is not
only an important question, it's quite an evolving topic, I will say. What happened is, previously people used to think, say for example, if a man presenting with lower urinary tract symptoms, it's due to prostate or the bladder. If a woman presents with the storage symptoms, it is due to overactive bladder. That particular calculation and sensation is now gone. The thinking is now more towards to see the actual etiology rather than thinking about the organ, like whether it's prostate growth or overactive bladder. And if we connect the dots, even in our practice, we were able to see so many patients are presenting with other comorbidities like medications for hypertension, diabetes, cholesterol, previous heart problems, and mainly obesity also. If we see retrospectively, the chances of you coming across a patient with urinary tract symptoms, either voiding or the storage, but has no medications, quite thin built, quite healthy, going for gym 2 times a week, and then having a very active lifestyle, good kind of food pattern, it's almost non-existent. Patients always have a complex of other things also. And when they looked into it, and if they go for a complete package treatment of weight reduction, making sure the food habits are getting better, and a kind of a wholesome approach, the prostatic symptoms also improves. So then only this concept of muscle is a new endocrine organ, where if there is a person with good resistive and aerobic exercises having some good amount of muscle, the muscle will help to maintain a good glucose levels and also prevents insulin resistance and protects all other normal metabolically accepted diseases like diabetes, hypertension, and also takes care of the lower urinary tract symptoms.
That I agree. But whether these skeletal muscles fulfill the criteria to call it endocrine organ?
Yeah, if you see this one of the slides, I mentioned quite clearly what are all the things secreted by the muscle, like myokinase. And that myokinase indirectly affects the brain-derived neurotropic factor. It indirectly affects the pancreas, insulin secretion, and resistance. So it's like a chain reaction. So that's why endocrine organ is defined as an organ whose secretion is going to affect distant organs with the blood supply. So that exactly happens with the muscle. With myokinase, due to activity, affects the distant organs, Alzheimer's disease, brain-related problems, metabolic syndrome, obesity, everything, including urinary symptoms.
Thank you. Thank you very much, sir. So is there any questions from floor to Dr. Anand? If not, then if there is any question to Dr. Deepak Thakur? If not, Dr. Bipin Rai? So I have got a question. So whether this laser HOLEP, you talk about the incontinence, in that conditions, that whether that is applicable to the TURP, those things we have been doing, applies the same thing which you talk about?
The things that has been studied is also applies in case of TURP, because mostly the process that we operate have expansions of their distal aspect beyond the vero. So everybody know. So if you can maintain the lysosphincter, that means the mucosal and submucosal portion distal to the vario, it has been shown to have increased the continence even in patients with large prostate and even in TURPs. So the advice is that maintaining around 1.5 centimeter of distal mucosal bridge or a mucosal tag is very important in maintaining continence even for TURP.
Yeah. Not to stretch too much
Yeah.
laterally, right?
Yes, sir.
Okay.
The thing with TURP is because we are going from midline to lateral, and most of the TURPs, however good we do, we don't reach the capsular area in all the places. So there are some places where capsule is exposed, but not all the capsule is exposed, even in best TURP cases. But in HOLEP, we are going with the capsule throughout the area. So the stretch, circumferential stretch is much higher in HOLEP as compared to TURP because we are not reaching the periphery. So that means this stretching aspect maybe applies less in TURP as compared to HOLEP. But mucosal coaptation, because of the cheese grater effect in case of TURP, may have implications in maintaining the mucosal coaptation if the length of mucosa that's covering the rhabdoid sphincter is not sufficient.
Thank you. Thank you very much. We have come to the end of this session.
So-
Thank you all the speakers.
Thank you, chairpersons and all the speakers. Now I would like to request to conclude the session by a group photo of chairpersons and speakers. Please come to the front for the photo.
Good morning, everyone. Because I think the session ended early, the chairpersons for the next session are not here. Maybe we'll start in 5 minutes after the chairpersons are here.
Okay, a very good morning to all the participants and the presenters. We are starting with the uro-oncology session, and may I call upon Dr. Nirmal Lamichane, and he's going to talk about bladder preservation on TMT in muscle invasive bladder cancer. Dr. Lamichane.
Respected chairs, dear seniors and colleagues, I will be talking on trimodal therapy in bladder cancers today. Today's objective would be to understand the rationale and for bladder preservation in MIBC, review of modern TMT protocols, identifying some optimal patient selection criteria, and discuss some long-term oncological and functional outcome, as well as role of some immunotherapeutic agents in TMT paradigm. In the background, muscle invasive bladder cancer, nowadays we consider standard treatment would be radical cystectomy, and the radical cystectomy is associated with significant morbidity and quality of life impact. Once you do it for some time, you will understand how morbid this surgery is, and especially in an area where the patient support system is not very, very good. The patients are suffering and they come back to you, and when you see them, you really want to think about it again. And definitely there is a need of organ sparing, oncologically non-inferior alternative for this radical cystectomy. When you look back at our own data, we do about 35 to 40 cystectomies in a year. A majority of them are urothelial cancer. If you see from this particular table, you should be able to see majority of them had cystectomy followed by ileal conduit, and we used to make some ileocecal pouches. We also make some continent orthotopic diversions, but when you follow up these patients for some time, you will be seeing a lot of problems causing these patients' life miserable. If you see the survival curves, we were able to analyze 2-year survival is overall survival is about 76% and 5-year is about 51%. They are not living very long. Stage-wise, the scenario is same. T1 lives longer, T3 lives shorter. N stage-wise, neural status. Whenever there is a N1 or N2 disease, the survival scenario is abysmal. So the need of the time probably would be neobladder. We think it's good, but it's not as good. Organ preservation in other organs like breast cancer and some other organs are widely practiced in oncological care. There is a success stories backed by evidences initially for non-surgical candidates. Then it has been applied in surgical candidates as well. The rationale here is a maximum tumor debulking with TURP improves local control, and there are radiation therapies in very, very modern techniques that yields better results with less toxicities nowadays. And the chemotherapy is a radiosensitizer as well as concurrent chemotherapy, and probably the newer molecules like some immunotherapies and etc. are upcoming. And it has really given a comparable cancer survival in select patients. If you see this busy table, you will be seeing this is been tried in non-surgical patients initially with different regimens of chemotherapy along with three-field radiotherapy, conformals, VMATs, and etc. with some results. And some of the data shows the survival benefits. 5-year survival, disease-free survival are almost equal to radical cystectomy. In newer series, if you see, phase 3 randomized controlled trial, it's been reported by phase 2 trials by radiation oncology groups, where they applied maximum TURBT along with cisplatin-based chemotherapy and some form of conformal radiotherapy. Then disease-free survival for 5 years is about 71%, with overall survival of 57%, with good bladder function. I mean, this is the most important thing probably for a patient. So this definitely confirms the feasibility and efficacy of this particular type of treatment, which has been reported in Journal of Clinical Oncology in 2014. And the enthusiasm ever since has grown, at least, if not across the Atlantic, in the European area. This Lancet Oncology article, which is essentially combined series studies where about 1,000 patients were analyzed who had undergone radical cystectomy with trimodal treatment. The results were, the median follow-up was 4 years plus, and you can see the overall survival with radical cystectomy is about 66% compared with TMT was 73%. And the outcomes for radical cystectomy and trimodal therapy were not statistically different, but you can see the numbers. Number-wise, the TMT patients are more in numbers. So this multi-institutional study essentially gives an idea that it definitely showed some, at least not, if not beneficial, similar oncological outcome. And it also says these results support the trimodal treatment in setting of multidisciplinary shared decision-making should be offered to all suitable candidates with muscle-invasive bladder cancers, and not only to those patients with significant morbidities and who are not considered as a surgical candidate. I mean, this has brought this topic for at least for discussion with the patient. If it is so, there are various ways of treating a patient. There are no homogeneous ways how these patients should be treated. So, what is modern trimodal treatment, trimodal therapy then? This is a definite organ preserving therapy for MIBC, where there are three components. If you see, there has to be a maximal TURBT, essentially means with a goal to remove all the visible bladder tumors, and the radiation therapy in the form of image-guided bladder filling protocols. These has to be in the form of SBRT or at least in the form of VMAT, and the systemic therapy in a concurrent or as in sequential manner, especially platinum-based chemotherapy. And these patients has to be under strict surveillance with early salvage cystectomy whenever needed. And these has not to be skipped. And the overall goal is to preserve bladder along with intent of cure. So the TURBT we discussed, the maximal and the visible complete resection, and there has to be absence of residual disease. And we always can do a re-TURBT whenever initial resection is incomplete. Radiotherapy-wise, this is an overall thing. The definitive bladder radiotherapy with 55 to 60 gray radiation, and the fractionation can be in conventional format or in hypofractionation. And techniques would be IMRT, VMAT, IGRT, or adaptive RT if possible. And the bladder motion management, if possible, has to be incorporated. There are image-guided RT nowadays because the LINIAC machines or other machines, wherever available in the world, are new generation nowadays. So many of them has got these type of new modalities of treatment. So this is possible wherever the radiation machine is. This is not like we use a TURP machine for last 20, 30 years, and some of the things are not there in even newer systems. The systemic chemotherapy-wise, protocol essentially has to contain cisplatinum whenever possible. Whenever not possible, there has to be gemcitabine-based therapies. Here, the patient selection criteria still remains a standard thing that you have to consider. The ideal candidates would be T2, T3, at least T3A disease. There has to be N0 and M0. And I mean, if possible, unifocal tumors, no extensive CIS. And anatomy-wise, the site has to be easy for TURBT to attain a complete resection. And of course, has to be a medically fit patient to receive chemotherapy here. And the initial bladder function has to be good. Relative contraindication would be extensive carcinoma in situ, hydronephrosis, multifocal bulky tumors, poor bladder capacity and function, and the possibility of non-compliance with the follow-up. With these, the complete response rate can be as high as 70 to 80%, as we discussed in the previous articles. Fiber survivals can reach as high as 50 to 60%. Overall survival, disease-free, up to 75%. And 5-year bladder intact survival, which is probably a more important issue we need to raise here, can be as high as 50%. Functional outcome-wise, the bladder function majority of time remains intact and acceptable in 70% or so of the patient, and late grade 3 toxicities are less than 10%. Bowel function-wise, there is less bowel toxicity because of the modern radiotherapy techniques, less than 5%, and quality of data-wise, quality of life-wise, the superior body image and sexual functions are observed. Nowadays, in oncology, if you don't talk about immunotherapy or targeted therapy, that will be incomplete. So there are a couple of trials ongoing where in Keynote 992, the pembrolizumab has been added in the trimodal treatment, and in NGR GU1008 trial, azacitidine and durvalumab is added, and these trials are ongoing at the moment, and we don't know the exact things, but early data says the good results. If you see here, the modern TMT roadmap would be a multidisciplinary tumor board discussion has to be there because these patients has to be treated with multiple specialties of oncology. The maximum TURBT, if re-TURBT if needed, and staging, CT, chest, abdomen, pelvis, if possible, PET scan for high-risk disease, and patient selection in shared decision-making process. Simulation and planning for a radiotherapy in the form of IMRT or VMAT on a concurrent chemotherapy, as we discussed, and response assessment with a cystoscopy and TUR biopsy in 3 months' time, and surveillance cystoscopy plus CT scans in 3 to 6 months' time are necessary for this protocol to follow. The toxicity-wise, there is some dysuria, frequency, and diarrhea because of chemotherapy, and late bladder fibrosis, hematuria, and reduced capacity are observed in few of the cases. So, we need to talk about salvage therapy here because some of the patient may fail. So, for low focal recurrences of non-muscle invasive type tumors, you can always do a salvage TURBT with intravesical treatment at this time. For those with invasive recurrences, which is about 10 to 30% of the time, and or in incomplete response, at that time you should be doing a radical cystectomy, and it is said that the outcomes are very much comparable with the upfront radical cystectomy. So you don't have to worry much if these patients are compliant in your follow-up schedule. Follow-up wise, cystoscopy, 3 months in first 2 years, imaging surveillance for metastatic workup, urine cytology always has to fall in the line, and the bladder function assessment if there are some issues. So the take-home message at the end would be trimodal treatment is a valid curative option in select MIBC patient with a okay overall survival, similar overall survival. Proper patient selection is key to success here because we don't have personalized genomic analysis that can be used straightforward on the table for us at the moment. So we still have to manipulate whatever data we have for the selection of cases. And long-term outcomes are excellent with preserved bladder function and quality of life. Immunotherapy is promising addition, but still investigational at the moment. And we should not forget MDT discussion making is essential for every patient to reduce the professional bias here because we sometimes surgeon finds a patient and there is high propensity that patient might undergo surgery if someone else, some other treatments will be commenced. With this, I thank you here for your kind attention and I'm happy if there are any questions to be answered.
Thank you very much. Are there any questions on the floor?
To be honest, I also did in couple of cases who are surgically unfit. And what I found was promising. And I'm very much inspired at the moment. We should be discussing about this with every of our patients, and we should be doing it and seeing it.
Thank you, Dr. Nirmal. I think we have a couple of time at the end for the question and answer session. So we'll move forward with another presentation.
Thank you.
It's on a radical cystic prostatectomy, ileal conduit and new bladder formation by Professor Robin Joshi. It's over to you, Dr. Joshi.
Thank you very much for chairpersons and dear friends. I'll be briefly discussing about the radical cystectomies, some indication scenarios and some recent advances. So I think the presentation by Dr. Nirmal has highlighted some of my issues. So it's the 5th most common cancer, and 90% is tangential carcinoma, and out of that 70 to 80% in NMIBC, and rest are muscle invasive. So why muscle invasive is important? Because it has a high risk of progression and metastasis. The goal of our treatment should be always oncological control with survival benefit and quality of life. So what is the standard of care? It is always, as Dr. Nirmal mentioned, a lot of presenters yesterday said it is RCP and diversion. It includes removal of bladder, prostate, seminal, as we all know that, and the extended PLND is recommended and has a good oncological outcome. Is recommended by different guidelines as well. So what are the indications for RCPs? Like it is muscle invasive T2 and above, BCG refractory by NMIBC, some variant histology, and if the prostate is involved, then the indication is RCP and some. So what are the advantages of radical cystectomy? It's the gold standard treatment. As you all know, whether you do it open, you do minimally surgery, we do laparoscopic or robotic. So it is suitable for bulky aggressive tumors, CIS, hydronephrosis, because it gives you best local disease control, complete tumor removal, and there is an added advantage of PLNT, because it gives you best oncological, long-term oncological control with accurate pathologic staging, because it gives you the further time for your treatment and prognosis and further treatment also. There are many disadvantages, I know, because as TMT is for very few selected patients. But to name some disadvantages, it's a major surgery with morbidity. It impacts your quality of life. It has a sexual dysfunction, and there are a lot of urinary diversion issues. So, is it ideal for the unfit patient or the elderly patient? So, I have some few scenarios, like for T2 patient organ confined. The recent advances, the recent protocol is you go for a neoadjuvant cisplatin-based chemotherapy, because it's a level 1 evidence with SOAK trial, Grossman et al. So they've all said there's a 5 years overall survival benefit of 5 to 10%. If you come to locally advanced, it's a multimodal approach. Wherever possible, you have to go for radical cystectomies. And then the extended lymph node dissection improves staging accuracy. And if you can add adjuvant immunotherapy, as was mentioned by the previous speaker, there's a checkmate trial, and then there's Bajorini et al. Saying adjuvant immunotherapy improves the overall survival. If you come to high-risk NMIBC, there's always a role of upfront RCP, and those who has gone for TURBT and re-TURBT, BCG, and those who are unresponsive for BCG, there's always a role of radical cystectomy, and it has been proved by many guidelines too. Coming to the fourth scenario in elderly and frail patient, the role of TMT is always there, but it's always for a very highly selected patient. And addition of concurrent chemoradiotherapy, there is a patient may not be fit for chemotherapy, and if the patient is subject to radiotherapy, there are a lot of issues of radiotherapy, complication and whatnot. And the best thing is the bladder preservation approach. And in these cases, if you go for salvage cystectomy is always difficult than the primary cystectomies. And if you can add open surgery, we have been doing in Nepal, in a lot of world also, they're doing, many cannot afford robots. So what we are doing is we are doing mini lab open retroperitoneal approach. So I had one paper published in 2019 on the elderly patient with acceptable morbidity. So what are the surgical approaches? We know that we have open, it is a traditional approach, is a well established with good oncological outcome, and minimally invasive approaches with laparoscopic approach, robotic approach. Laparoscopy, I think there was a presentation by yesterday from Bharatpur Cancer Hospital with 200 cases. That was a very good one, very good paper. And on the robot, if you can afford, well and good. It's always the cost that counts, because there are pre-operative benefits like less blood loss, shorter length of stay, and lower blood transfusion. But the oncological outcome is comparable with the open and the robotic. So if you see this razor trial, the open and RIRS is not inferior to each other. The only thing is the morbidity that is good in the robotic arm. So if you see 2-year PFS, it's almost similar. If you see extended follow-up for 3 years, overall survival is almost similar. If you see Kaplan-Meier's graph, the razor trial states that you can see the graph, it is almost similar in PFS. Even in overall survival, it's almost similar, comparing robotic and open arm. And coming to urinary diversions, it's a critical component of RCP. So many high-volume centers show that ILL conduit remains the most reliable option in the octogenarian or frail patient. And if you follow ERAS protocol, it further reduces your surgical morbidity. So why ILL conduit is good? Because it has shorter operative time, lower early complication, even in the high-risk patient, better suited for frail and the elderly patient. And cons, it has an external appliance, which is difficult to manage sometimes. It's the body image, and there's a lot of stoma-related complications. If you come to orthopedic neobladder, It's a small segment of a small intestine configured into a reservoir, and there are a lot of, I don't want to go into detail, there are a lot of Indiana pouch, Tudor pouch, and pitcher pouch. Why is it good? Because it allows more natural voiding, no external appliance, better quality of life in selected patient, preserves body image. And if you see the difficult part, it is technically demanding, needs high surgical expertise, higher early morbidity. We have a lot of anastomosis. You can have anastomosis, you have intestinal leaks, you have ureteroileal leaks, and requires preserved urethra and good renal function for these orthoptic neurobladder. So what are the recent advances? As we have heard a lot of robotic surgery yesterday. So RAIN, robot-assisted intracorporeal neurobladder construction using standardization technique like improved suturing method, stapler-assisted bowel configuration has added advantage on the robotic surgery. So if you come to recent advances, as was mentioned by the previous speaker, that addition of adjuvant nivolumab by CheckMate trial, the DFS is significantly improved, overall survival is significantly improved if you can add adjuvant nivolumab. And the recent one is the ctDNA prognostication, ICG fluorescence for perfusion assessment in a neobladder case, and intracorporeal neobladder standardization. So what is CT-guided therapy? It is a fragmented DNA detectable in plasma. Circulating tumor DNA is emerging as a prognostic and potentially predictive biomarker in patient undergoing radical cystectomy for urothelial carcinoma. So the same thing that I'm saying, if you see the Kaplan-Meier, the DFS is significantly improved. If you see disease-free overall survival is significantly improved on adjuvant therapies, on immunotherapy, the recent immunotherapies. So if you see 2025 cross-sectional studies, neobladder group had better emotional function, urocutaneostomy group had higher fatigue scores, ileal conduit had intermediate scores. So bottom line is divergent type significantly influences the quality of life. So I have some small video to present. So if you see this, we have just completed, we have done, removed the bladder and the prostate. I'm not showing the previous part because we didn't have a good picture. So we are constructing a new bladder here. It's a picture pot, about 55 centimeter. And constructing the neobladder with 55 centimeter of ileal, distal ileum. And this is the access loop of 15 centimeter. So what we are doing is to reduce the time you are using staplers. So it reduces your half hour to 1 hour of time for the ileal reconstruction. And the formation of the neobladder. And we make a new urethra of 2.5 centimeter length as well. This can be done in a robotic way also. But unfortunately, we are very poor enough to have a robot in Nepal and to acquire one also and to work on it also. And most of us who are doing a radical cystectomy, if they have a robot, I think these things, the one I told you, recent advantage, the standardization, this thing will really decrease the morbidity and with good oncological outcome. So this is ureteroileal anastomosis. Sorry about the picture, it's not. So we are putting the stents. And almost complete neobladder. So this is the closure of the anterior wall and putting a SPC. So new urethra is being reconstructed. And if you see this, there's a new urethra anastomosis, a very good one. So if you see this picture, you'll see it, we completed in just above 4 hours time. So this is how it looks, the neobladder one. Just 10 centimeter incision, way below umbilicus. These are few stents here. And then this is another one is the conduit picture. Again, we are doing the retroperitoneal approach, retropubic approach with minimal handling of the tissues. And this is how it looks, the neobladder, how it looks. And sometime you might have a chance to work in a robot. There's one small video. And I thank one great person who has allowed us to work in a robot as well. This is one of our cases that we did. So I'll just skip this. Right? So this patient, I have few patients who are undergone neobladder formation. This patient is now in 7 years of follow-up. This patient is under 6 years of follow-up. This patient is under 8 years of follow-up. To conclude, radical RCP remains the gold standard treatment for MIBC. Robotic approaches is expanding globally. Integration of immunotherapy is shaping the future care. And the one we are doing mini-lab retropubic approach has a very sound ground in the context of Nepalese scenarios. Thank you very much.
Thank you, Dr. Robin. We move on to next presentation as we have question and answer session at the end. So the next presenter is Dr. Hilary Fernando. He will be talking on extended versus limited pelvic lymph node dissection in prostate cancer. Do we still need extended PLND in the PSMA PET era? Dr. Hilary, please.
Very much, respected chairpersons, ladies and gentlemen. A very good morning to all of you. I would like to take this opportunity to thank the President, the Council, and the Scientific Committee of NOWS in giving us this opportunity. And my task today is to talk to you about extended versus limited pelvic node dissections in prostate cancer. Do we still need extended pelvic node dissections in PSMA PET era? I have no disclosures to make. Extended pelvic lymph node dissection is the gold standard for nodal staging in intermediate and high-risk prostate cancer. Extended pelvic node dissections improve staging accuracy compared to the limited, but of course at a cost of higher morbidity. Now, with the emergence of novel modalities like PSMA PET-CT, if we can see the nodal disease preoperatively, do we still need to remove the pelvic node surgically, sustaining all these adverse effects? That is the question we all have here. So these are the indications for extended pelvic lymph node dissections: high-risk disease and the intermediate risk disease where the lymph node invasion risk exceeds more than 5%. And these are guideline based on EAU and CCN. And this can overall be avoided in low-risk localized disease when the lymph node invasion risk is minimal. Problem with these novel imaging modalities, including MRI and the PSMA PET, they often fail to detect small micrometastatic diseases in the lymph nodes, which is well detected in these dissected out specimens. And 80% of all these early mets are smaller, maybe 5 or 7, less than 7 millimeters in diameter, which often lies below the size criteria for those. So these are the two templates I'm going to talk. The limited, which includes obturator nodes and the external iliac nodes, and the extended. This includes obturator, external, internal, plus or minus common iliac and plus or minus presacral nodes. So this is established because extended pelvic node dissection detects 2 to 3 times more nodal mets than the limited template, and 50 to 25% of positive nodes lie outside the limited or the obturator and the external iliac node groups. Both EAU and the American Urology Association recommends extended pelvic lymph node dissections in patients in whom the lymph node invasion risk exceeds 5%. Do we have a therapeutic net benefit in extended pelvic lymph node dissection over limited? It's unproven, but only a subgroup analysis with very high risk prostate cancer. In a recent RCT, they have detected a little sort of a therapeutic benefit in preventing further metastatic disease. So this randomized control trial from the European Urology, published in 2021, extended versus limited pelvic node dissection during radical prostatectomy for intermediate and high-risk prostate cancer, early oncological outcomes from a randomized phase 3 trial. This concludes extended pelvic node dissection provides better pathological staging, no difference in early oncological outcomes, and subgroup analysis suggesting a potential biochemical recurrence-free survival benefit in patients with ISUP grade group 3 to 5. This is a RCT from the Memorial Sloan Kettering Cancer Center, limited versus extended pelvic node dissections for prostate cancer. This is early evidence from 2021 again. This shows no biochemical recurrence difference between the two groups. And the same group publishes again in February 2025 with a median follow-up of 5.4 years. So they claim clinically and statistically significant protective effect of extended pelvic lymph node dissection against further metastatic episodes. And they recommend an extended pelvic node dissection, reduce incidence of metastasis, and patients undergoing radical prostatectomy, if they are to receive pelvic node dissections, should rather receive extended pelvic node dissections. So what morbidity is related with extended pelvic node dissections? The lymphocele, thromboembolic events, nerve injuries, vascular injuries, and increased operative time. Meta-analyses confirm significantly higher complication rates in the extended group compared to limited groups. So PSMA PET-CT has revolutionized staging in prostate cancer. Before that, we had the contrast-enhanced CCT, the CT and the bone scan. And the PRO-PSMA trial compares this previous gold standard versus the PSMA PET-CT. And there is superior accuracy compared to CT plus bone scan, greater specificity of over 95%, and sensitivity of 40 to 60% for detecting small nodal metastatic disease. So again, this is results from the PRO-PSMA study, superior accuracy, greater treatment impact, and fewer uncertain results in the PSMA PET arm compared to the conventional CT plus bone scan arm. These are images detecting small lymph nodes in the pelvis, and you can see in the normal CT you can't actually detect any difference in these. So the limitations of PSMA PET-CT: poor detection of micrometastases which are smaller than 5 millimeters, and approximately up to 10% of prostate cancers can have low PSMA expression, making them harder to be detected by this method. And some of the aggressive cancers which actually were visible on PSMA PET may lose the PSMA expression over time, especially after multiple cycles of treatment. Therefore, positive PSMA is highly reliable for nodal mets. The negative PSMA does not guarantee the absence of micrometastatic disease. So can PSMA PET-CT replace extended pelvic node dissections? So these are further against this. In high-risk patients, up to 10 to 15% have negative PSMA, but positive nodes on the pathological specimen. Studies comparing the PSMA versus final pathology show negative predictive value is insufficient to safely omit extended node dissection in the high-risk disease categories. In low to intermediate risk, suppose the PSMA is negative, the nomogram is less than 5% for lymph node invasion, then you can safely omit lymph node dissection. The emerging risk adaptive strategies may combine these PSMA findings, the nomograms, and the tumor characteristics in coming years. Again, the PSMA showing the primary tumor, bone mets, and the lymph nodes in the pelvis. So what is the current guideline position? The EAU, the extended pelvic lymph node dissection is recommended with more than 5% nomogram risk, and the NCCN PLND remains the gold standard. So where are we heading in the future? Maybe PSMA radio-guided surgery, sentinel node mapping, molecular staging, AI integrated imaging, and in the future is definitely selective extended pelvic node dissection rather than universal extended pelvic node dissection. So in conclusion, ladies and gentlemen, PSMA PET-CT has changed staging in prostate cancer. It has reduced uncertainty in diagnosis. It has improved patient selection to different treatment arms in a more reliable way, but it is yet to diagnose microscopic disease. So the extended pelvic node dissections, it remains the most accurate staging modality for the time being. It still has unclear therapeutic benefit, requires selective and individualized use in each patient to cater individual needs, at least need internal, external, and obturator groups to be called extended node dissection. So do we still need EPLND in the PSMA era? Yes, but not for everyone. The future lies not in abandoning extended node dissection, but in redefining its indication. So again, ladies and gentlemen, consider EPLND in high-risk disease, more than 5% nomogram, even negative PSMA, but significant clinical suspicion, and results will change adjuvant therapy decisions with PSMA and with extended node dissection. You can omit EPLND, nodal risk is less, significant comorbidity with the patient, and no therapeutic consequence. No, it's not going to change the therapy for this patient. You can safely avoid. So with that, I conclude my talk, and I would like to warmly invite you all for SLOUS 2026, which will be held in Cinnamon Lakeside in Colombo. And our website will soon display all these details, and there is a cadaveric workshop which will be of great interest to all the trainees. We have had 2 such training programs in the last year, and this will be under the South School of Urology, and all the trainees in the region are warmly welcome. And you can also participate in the conference in the Urology Week as well. So this will be in the vibrant city of Colombo, and last time we had it in Kandy, and hopefully I'll be able to see many faces in Colombo later this year. Thank you.
So thank you very much, Dr. Fernando. We move on to the next presentation by Dr. Umesh Nepal, and he's going to talk about the past, present, and future in the treatment of metastatic hormone-sensitive prostate cancer. Dr. Umesh.
First slide, please. Morning, everyone. Before starting, I would like to congratulate NOUS for organizing such a wonderful academic event and also thank them for this opportunity. Yesterday, Professor Uttam Mehte described in detail about the locally advanced prostate cancer. Today, I'll be talking a little bit about the metastatic disease. The reason for selecting this topic is that we still get a lot of patients with metastatic prostate cancer, though the number of cases of localized disease is increasing, but still in our day-to-day practice, the number of patients of metastatic disease is very high. And the management-wise, most of the patients I see, we find that they are either incompletely treated or not treated properly. So I would just like to stimulate how the paradigm is shifting and how we should move forward. I have nothing to disclose. I'll talk brief about the history, then how we stand in the present, and then how the future is shaping ahead for the patients with hormone-naive prostate cancer. Any talk of prostate cancer will be incomplete without remembering Dr. Charles Huggins. He is the one who said that the prostate cancer, he identified that the prostate cancer is an androgen-dependent disease, and then AR is highly expressed on PCS cells and directly stimulates growth and survival of these cells. For this, he was awarded Nobel Prize in the year 1966. This is the menu which has been tested widely, practiced widely in the last 7 decades, and we have been changing and chopping around among all these options. Talking about how these different drugs work, there are many different drugs which are recommended in prostate cancer. Some work by inhibition of the synthesis of testosterone and the byproducts like abiraterone. Some work at the cell membrane receptors. Some work in the cytoplasm, or like ARPIs like enzalutamide, apalutamide. And some of the agents, they work inside the nucleus, like PARP inhibitors, olaparib, and others. So the proven strategy so far has been either chemohormonal with ADT and mainly docetaxel, and other ADT with other ARPIs like abiraterone, enzalutamide, or apalutamide. And a new drug, darolutamide, has come recently, showing promising results. And the multiple combinations of these, as we will see with my presentation ahead. There are some newer agents which are being tried and which have been recommended, like, as I said, PARP inhibitors, as shown to have positive results by Amplitude or TARAPRO-3 trials. 177 lutetium PSMA, it's a radioligand therapy, as shown effective by PSMA addition trial, either alone or in combination with other agents. Pembrolizumab is a drug. It is showing promising results from everywhere in uro-oncology, from kidney to prostate, and other agents like capivasertib or abemaciclib as per the Cyclone-3 trial. And talking about artificial intelligence, I'll talk about briefly in my later slides. Artificial intelligence is also coming up in prostate cancer diagnosis and management. Any talk of metastatic prostate cancer is incomplete if you do not touch about the Charter trial. This formed the mainstay where using docetaxel in case along with ADT for metastatic cancers, especially in the high volume disease. These are the various survival curves of the Charter trial, showing a positive advantage of adding docetaxel, especially to the high volume metastatic disease. Stampede, I'll touch briefly about Stampede, which also showed a positive result of adding docetaxel to the standard of care. This is a meta-analysis taking into account all these studies, and it concluded that docetaxel plus ADT should be considered as standard of care for men with metastatic CSPC, of course, for those who are fit for chemotherapy. And this formed the basis of what we stand now of using ADT with a chemotherapeutic agent docetaxel for the management of these patients. This is the summary of the different trials from Charter to Aranote. I said the new agent darolutamide has come up, has shown positive results by these two trials, Arescence and Aranote trial, published in 2022 and 2024 respectively. These are the various guidelines recommending all the different agents like docetaxel, abiraterone, enzalutamide, all showing a strong indication, a strong favor for these agents. Now, from 2015 to 2020, 2021, docetaxel became a very important drug in the management of these patients. But around 2021-22, people tried to think, is it enough? Only is the docetaxel and the ADT enough? So they tried to add various combinations, calling it a triplet therapy or even quadruplet therapy. They said that we have to hit it hard and hit it early when it's possible. So then the combination therapy, the triplet treatment regimen concept started back then. These are the pivotal trials evaluating triplet therapy in metastatic hormone-sensitive prostate cancer. Enzamet comparing ADT, docetaxel, and enzalutamide. Then PEACE-1, ADT, docetaxel, abiraterone, prednisolone. And ARASENS, ADT, docetaxel, and darolutamide. And all of them showing very good results, especially in synchronous and high-volume disease. So how do we decide? How to know which patient to intensify and which patient to de-intensify? And this was a paper published last year in 2025, Age and Treatment Intensification in Metastatic Hormone-Sensitive Prostate Cancer. And it shows that in young patients, by young I mean less than 70 years of age, the addition of one more agent, one more ARPI to the standard of care definitely has an advantage. We can see the two survival curves separating in these patients. These are the current combination phase 3 trials in metastatic hormone-sensitive prostate cancer. They are trying various combinations, PARP inhibitors, ARPI, and ADT in Amplitude Talapro 3 trial. AKTI and ARPI is added in combination with ADT in Capitolo 281. And as I said earlier, lutetium PSMA in PSMA addition trial, and all. These trials are ongoing, and with the final results, we will be able to decide easily. But the most important thing is cost. Here we can see that with the addition of the different agents, different ARPIs, the cost of treatment goes very high. We can see it's in thousands of dollars. But our patients, they are very poor. They are not as economically sound as the Western world. So for these patients in our part of the world, still ADT with docetaxel is the main line of treatment, because docetaxel is very cheap as compared to these agents. I'll show you an example. The docetaxel available in our pharmacy for 6 cycles, it only costs around $250. But the different ARPIs, abiraterone, enzalutamide, apalutamide, the combination treatment overall cost is in thousands of dollars. So we have to look into our patients' pocket as well. This is a study published last year. It was a meta-analysis, a comparative survival in metastatic hormone-sensitive prostate cancer by volume of disease and timing of metastasis. And they concluded that current evidence suggests that the triplet systemic therapy is preferred for patients in systemic high-volume hormone-sensitive cases and who are fit for surgery. So in synchronous high-volume, yes, addition of one more agent has been shown to be effective. So this flowchart was postulated. They said that these patients are divided into synchronous metastatic disease and metachronous, then synchronous further divided into high volume and low volume. And that too further subdivided into if the setting is a resource-rich setting or a resource-constrained setting. If it's a resource-rich setting, then definitely abiraterone, docetaxel, ADT, or darolutamide, docetaxel, docet, SDT is helpful. But in our part of the world, the patients are poor. Still, as I said earlier, docetaxel and ADT is the standard of care for now. This is also come up in the latest NCCN guidelines, the ADT and docetaxel with one of the ARPIs in high volume diseases. But how are the physicians and the urologists treating or oncologists treating our patients? This is the data from United States. I could not find the data from our part of the world. This is the change in treatment from 2016 to 2019. The blue one is ADT only. The orange one is ADT plus ARPI. and the brown one is ADT plus chemotherapy. The ADT plus chemotherapy is decreasing slightly. The ADT plus ARPI is increasing, but still, we can see the blue. Still in year 2019, 62% of the patients in the United States are only receiving ADT in metastatic high volume disease. So what the scenario is grimmer, must be grimmer in our part of the world, even when this scenario is in the United States. So this was extensively studied, extensively discussed in the year 2024-25 ASCO meeting. So they tried to see, is it enough? Do we need novel agents to define how our patients will respond to treatment? And they also tried to incorporate artificial intelligence into decision making. So this was also published last year. They tried to compare the 3 genes, the aggressive variant prostate cancer associated tumor suppressor genes, TP53, RB1, and PTEN, and how the presence or absence of the mutations affect our patients. So they concluded that their findings reveal for the first time that aggressive variant prostate cancer tumor suppressor gene status provides additional prognostic and potentially predictive information beyond traditional clinical variables in hormone-sensitive prostate cancer metastatic. This tumor suppressor gene status evaluation can reshape the prognosis and inform treatment selection, identifying a subgroup of patients with exceptional survival outcomes. And they said that if these mutations are not present, then we can go for de-intensification. But if these mutations are there, then intensified treatment approach should be started in these patients. So this was postulated. For example, if there is a PTEN loss or AKT mutation, then addition of ADT, ARPI, and AKT inhibitor. I'll take one or 2 minutes only. And similarly, if there's a presence of HRR mutation, they postulated that ADT, ARPI, and PARP inhibitor would be the best treatment combination for the patient. But as I said earlier, we still have to look into the pocket of our patients, and these are very, very, very expensive drugs. Last year's ASCO meeting, extensive discussion was there, and they said that for the future, we have to see the genomics of the patients, and according to the genomics, we have to decide for the treatment. For example, if there's a PTEN loss, ADT, ARPI, capivasertib. If it's a SPOP mutation, ADT plus ARPI. This is just a formula. This has not come in the guideline yet, but this is for the future. So further research is also ongoing for artificial intelligence and still finding other tools like circulating tumor DNA to guide the treatment. AI is also there for prognostication, risk stratification, and treatment selection. I'll skip. This is the personalized intensified treatment. If the intensification by a stage migration, I'll not talk about the oligometastatic. This is a separate entity altogether. These are the ongoing trials. Results we are still awaiting. So to conclude, the past was ADT alone. The present is ADT, docetaxel, and addition of 1 ARPI, especially in case of high volume disease. But future will be genomic profiling and AI-driven approach. Thank you.
Thank you, Dr. Miss. Now we'll keep the question and answer session for the end, and I would like to invite the speaker from Sri Lanka, Munipriya, to presenting on establishing a services for radical cystectomy, my journey. Over to you, Dr. Munipriya.
Good morning, chairpersons, ladies and gentlemen. Thank you very much now giving me this opportunity to share my journey on establishing service in radical cystectomy. Nothing to disclose. Early speakers speak about the bladder cancer. So muscle invasive bladder cancer need timely treatment. So T2 and T4A N0, M0 disease need radical cystectomy, standard a gold standard up to now. Establishment of sustained radical cystectomy service in low and middle resource setting is a struggle. Real world journey and my journey is little difficult. As you all know, indication for radical cystectomy as described by previous speaker, so I will skip this. And I could establish this service in Polonnaruwa and Kegol, which was currently I work in at Kegol, and I was the only urological surgeon for entire Polonnaruwa district during my time, and I will cover 400,000 population with 4 medical officers without any resident. So 24 hours, 7-day emergency services providing. Then I was transferred to my current station, that is Kegol District General Hospital, in August 2024. And now I am covering 800,000 population with 3 medical officers. When I started radical cystectomy service in both Polonnaruwa and Kegol, there were no experience in the institution. No standardized pathway for muscle invasive bladder cancer except TURBT and transfer the patient to tertiary care, that is National Hospital Kandy. Theatre logistics are not optimized for long duration oncological procedures such as radical cystectomy or the radical prostatectomy. So administrative advocacy for establishing radical cystectomy service, I developed the comprehensive proposal supported by current evidence on radical cystectomy, including survival benefit, perioperative outcomes, and the quality of life impact. Engage key institutional stakeholders, hospital director, surgical leaderships, and the procurement authorities. Then multidisciplinary alignment for service establishment is very important in radical cystectomy. So formalize the dedicated uro-oncology MDT comprising urology, oncology, radiology, pathology, anesthesiology, and stoma care and the ICU nursing team as well. Achieving consensus on standardized indications, workflow timeline, and rehabilitation and optimization protocols were developed. Strengthening surgical skills and team capacity, the implemented structured case-based learning through publications and mentorship at high-volume radical cystectomy centers, ensuring progressive obtaining of skills. Conducted comprehensive educational for the entire operating team, emphasizing coordination, workflow, and the role capacity. The standardized anesthesia protocol for major pelvic surgery, like thromboprophylaxis, optimized hemodynamics, analgesics, and intraoperative physiology. Introduce enhanced recovery pathway, integrating rehabilitation, early mobilization, nutritional optimization, and pain control strategies. Strengthening stoma care component among the nursing team, including the appliance selection, early complication recognition, and patient counseling. Then develop the implemented standard operating procedures, operation room setup standard, instrumentation, and the perioperative safety and the complication checklist. Formalized post-operative care pathway, especially for ICU and ward-based nursing officers. So this is one of my student neobladder steps. So utilize diagram. So I teach my nursing officers and my doctors utilizing the diagram, the stepwise visualized, the curative education video. So reconstructive surgery is new to them, so I have to teach each process and the post-operative complications as well. So key requirements secured with the development of infrastructure and the instrumentation is important. So with the time, I have improved the major pelvic surgery, the long instrument for the major pelvic surgery, then vascular staplers and the energy devices, which is very easy for surgeon to minimize the complications and the patient safety, improve the patient safety. Standardized pathway implemented diagnosis, rehabilitation, chemotherapy pathway, neoadjuvant and adjuvant. During these processes, always I explain to the patient and relative with the diagrams and the options available, that is neoadjuvant chemotherapy or surgery followed by adjuvant chemotherapy. Likewise, always I use to draw diagrams and give options in their clinic notes. Then surgical planning accordingly, and so follow the ERAS protocol and follow the surveillance images and the metabolic monitoring, renal function, stoma care and neobladder care. Then urethral assessment with check flexible urethrooscopy with the time. Key obstacles faced in early few cases. The main thing is the prolonged operating time, sometimes more than 6 hours of operating time. So then assisting doctors and the nurses were in learning curve. So high demand on ICU resources. Complication in early post-operative period in neobladders. Here I have to reopen the neobladder patient because of the urine leakage. So once I open, I could recognize this type of leaking because this is continuous irrigation we use after the neobladder formation to wash out the mucus. But the caregivers should look after whether the inflow and outflow is equal. If outflow is reduced, this will happen. So this is the lesson learned during that. So then, solution for these type of things, the procedure step mapping, assisting team fixed for the cystectomy list, and enhanced protocol for stoma care and the neobladder educational sessions arranged and the teaching sessions conducted. And to my, as a surgeon, I will easy if the residency is there, so I get used my colleague, senior registrars for assisting, so they can learn the neobladders, they can learn the radical cystectomy. At the same time, my life will be easy. So I have get down other colleagues. So clinical outcome, after establishing this thing, reduce operation time, initially sometimes 8 hours, now 6 or less. And median blood loss is reduced by 30% initially. With the energy devices, it will reduce further. And complication rate, the downtrend, and the length of stay reduced with the ERAS protocol, early initiation of adjuvant therapy due to better recovery. The conducting morbidity and mortality meetings and the 30 days and 90 days mortality review and the maintained database is important. So during these two hospitals, I have conducted totally 10 radical cystectomies, including 3 neobladders. So 30 days mortality 0, initial blood loss 850 to 1000 initially, but later reduced up to 250 to 300. So all received the adjuvant chemo because the initial neoadjuvant process is delaying the treatment. So impact on patient care. So ultimately, they reduce the referral to external centers, faster definitive treatment modality, better continuity of care in single center, and sustained uro-oncology service developed in my center, and improved patient satisfaction with the stoma care. So we can see the smile of the patient's face. And future direction in goal to expand to robotic and radical cystectomy is the future in globe, and introduce continent diversion more widely, develop survivorship clinics or smart app for follow-up patients, implement digital rehabilitation and the post-operative monitoring systems, establish regional training centers for doctors and the nurses. To conclude, the establishing radical cystectomy service is a transformative institutional journey with structured planning, multidisciplinary alignment, and the continuous quality improvement. We can achieve the high quality uro-oncology service in resource-poor setting even. So, biggest success, improve outcomes and the dignity of the patients with bladder cancer. Thank you.
Very difficult to establish the system and train our colleagues to start the new services in the country. So if you have questions, so we'll start few questions from the floor. So any questions to Dr. Nirmal? Because he has a huge a series of cases of radical cystectomy with bladder preservation in Nepal. He works in a cancer institute, BP Koirala Cancer Institute at Bharatpur. So any question?
Can I ask Dr. Nirmal a small question? So organ preservation in all the cancers are growing. The interest is growing. I think we are moving in that direction, be it kidney cancer or bladder. In your practice, how do you choose the patient? Because even the neoadjuvant therapy is advocated. Most of our patients, even us, we directly go for surgery. We skip neoadjuvant in, still we skip neoadjuvant in some cases. So in this scenario, how do you select the patient for TMT?
Honestly, this is the idea is you mindset has to be changed first of all, and by definition, a trimodal treatment is not an extension of neoadjuvant therapy or whatever. It's an idea that you first discuss with the patient in a multimodality MDT meeting, and then you decide if this patient is going for a trimodal treatment, and then you do a maximum TURBT because the staging and etc. has been already worked up, and then the followed up with a RT with concurrent chemotherapy and a strict follow-up protocol. So this has not been widely accepted by far because we always assume the radiation therapy will cause a lot of problem in the bladder. There will be functional issues, etc. in the future, and this has not been widely accepted. Probably because of cobalt machines were used in the past for radiation treatment. Even if the liniacs were used, but the treatment, I mean, there were not much conformal treatments given. But nowadays, the treatment, they plan the treatment in beforehand. If not the VMAT, SVRT and image-guided treatments are widely available. So the problems after radiotherapy is less and less. So we need to change our mindset first of all, and then we need to decide in pre-hand if this patient is for trimodal treatment or so. Neoadjuvant treatment essentially is before radical cystectomy. So you cannot just mismatch the things altogether.
I'm saying even though neoadjuvant is advocated, we still don't do neoadjuvant in some subset of patients. In that scenario, I'm not joining this, but with the emergence of immunotherapy for bladder preservation, cost is there, but what do you think with the introduction and with the popularization of immunotherapy, do you think that the proportion of bladder preservation will rise in future, or still the surgery will remain in the mainstay?
Yeah, obviously the issue with immunotherapy is the cost issue probably, I guess, but in conventional trimodal treatment, you can always use cisplatin or gemcitabine based chemotherapy and try it. Because the bottom line is, even if you do a cystectomy, if this patient fails, the survival is not compromised. This is the main message here.
I think what has come up in terms of hard data is the perioperative combination chemoimmunotherapy with the durvalumab along with gemcitabine cisplatin, something that is given in combination prior to surgery and then followed durvalumab continuing during the post-perioperative period. But I think it's interesting, and we have had the opportunity of listening to 5 exciting presentations looking at a perspective which is quite native to our part of the world. So, I mean, there is data available and coming from the West. However, we need to look at the local circumstances making decisions. So, thank you very much, Dr. Nirmal.
Thank you.
I have one question. Thank you, Dr. Nirmal. If you have started trimodal therapy for a patient, due to the timeline, if the patient changes his mind to go for, radical treatment, how would you counsel and tackle the patient?
To be honest, I mean, we are not widely using this modality. By far, the patient who had opted for trimodal treatment were those who were unfit for surgery. So at this point of time, in my assumption would be the autonomy of a patient should be respected.
So essentially, we need to understand that the protocols for trimodal therapy versus neoadjuvant chemotherapy is very different. In neoadjuvant, we use either dose-dense MVAC or we use gemcitabine, and we use 3 to 4 cycles. After 2 cycles, we do the CT scan and cystoscopy. If it is not working, we'll go ahead and go with the cystectomy. However, the trimodal therapy is basically with the radiosensitizer and starting with chemotherapy, continuing with the radiosensitizer, and then radiotherapy. So there are 2 different protocols. So it's important that these decisions are made right in the beginning, explaining the pros and cons, as Dr. Nirmal also explained, describing the pros and cons of both modalities, and once the patient has taken a decision, hopping from one to another is only going to benefit to decrease the chances of survival. Thank you very much.
Thank you.
Question to any of the other speakers that we have, and I must say that we have had opportunity of listening to 2 speakers, one from Nepal and one from Sri Lanka, about the use of orthotopic new bladder. Obviously, it's perhaps one of the most difficult surgical procedure, time-consuming, tedious, require not only the good surgical expertise, but very importantly, the perioperative care. And I think this is sometimes undermined in our part of the world, that the perioperative care of a radical cystectomy orthotopic new bladder is much more difficult than the surgery itself. And Dr. Manipuria described one case of bladder leakage, which is simply because of the poor nursing care, that irrigation going through, the outlet is blocked, and since it's an insensate bladder, this would rupture without any notice. And this is something that can be catastrophic, and it's very difficult to manage such situation. So it's important that we should develop a team which is able to take care of the patient. The surgeon is not going to take care of the patient 24 hours a day after surgery. So it's important that we have a good team which understand all the nitty-gritty of working in that setup to take care of these patients perioperatively. Yes, please go ahead.
Previously, when we started, we used to do irrigation, but now we have stopped using irrigation. And we keep SPC for continuous irrigation and suction of the mucus thing. And if you see in the robotic era, even they don't put SPC nowadays, if I'm not wrong.
Is a safety valve that you have. You have 2 hours of suturing and reconstructing a new bladder. It is potentially at risk of leakage. Third day onwards, the small bowel starts to work, and the mucus starts producing after 72 hours of surgery. And from that time onwards, you have to irrigate, because any of the catheters blocked, you may result in a rupture from the anastomotic line. So suprapubic is your safety valve.
Yes, this
so
is what we are doing.
It's preferable. Yes.
Thank you.
Can I ask one question to Robin, doctor? Yeah. You have nicely presented the cases of the neobladder reconstruction. And my question is what complications you have observed with this neobladder? My concern is actually in my cases, about 50% of the neobladder patients has developed some sort of the CKD, the raised creatinine, after 16 months or so. So have you observed any like this?
Can you please repeat the question?
Yes. Have you observed any CKD in neobladder patient? If there is any...
Till date, no. Till date, no. Because we do very highly selected patient. And we are not doing neobladder for the octogenarian or the older patient.
But it's I think it's a known complication of the neobladder, the raised creatinine. And
so if I may add, Dr.
Yeah,
Hillary, so the issue is really that you need to have very strict criteria for selecting patients for orthotopic neobladder. You need to understand that a small bowel created by nature is reabsorptive surface. So once that urine with high acid content comes to the bladder, it will be reabsorbed, and your kidney has to do twice the work, get rid of that acid load again. So if there is a compromised renal function, if the GFR is anything less than 50, you would not do a... Similarly for liver function, compliance of patient, all these factors are extremely important before you select your patient for a new bladder. Yes. The second thing that can happen, which can result in renal dysfunction, is an obstructive uropathy. So the ureteroileal junction is a potential source for obstruction. So it's important that you don't try and create any kind of a non-refluxing anastomosis. It's widely refluxing, and with the chimney, the chances of reflux is pretty low. So you made a wide anastomosis so that it doesn't get obstructed. Because it gets obstructed, there is very difficult to manage this patient.
Yeah, right, really right.
I think now we are already on a coffee break, where we utilize the coffee break as well here for the discussion. And we'll declare this end of the session, and we'll take another session after a short coffee break. Thank you.
I would like persons and all the speakers of the session to gather for a photograph. Thank you.
Uttam Mete for the chairpersons, and Professor Dr. Parasmani Shrestha as well to chair the session. And I would like to request the chairpersons to conduct the session. Thank you.
On the difficult reconstructive laparoscopic surgery. And may I request Dr. Shashikant Mishra to come and present and give his talk. Well, I'm very well versed with laparoscopy. He's the consultant urologist in Lucknow, and he has huge experience of doing laparoscopy right from his residency days. And he has established his own hospital at Lucknow, and he is going to tell us the difficult laparoscopic reconstructive surgery. Over to you, Shashikant. Please go ahead.
Thank you, sir. Thank you, sir. And at the outset, again, I would like to thank the organizing committee of NOWS for giving the opportunity to speak of this topic, which is difficult laparoscopic reconstructive surgery. We are all in era of robotic surgery, and the relevance of laparoscopic surgery is being questioned all around day in and day out. So I feel personally whatever we can do with robotic surgery, we can do with laparoscopic surgery. And therefore, I came to justify this topic, difficult laparoscopic reconstructive surgery. Now, as far as reconstructive urology is considered, most of these cases address the complex genitourinary defects and functional disorders. And laparoscopy offers minimally invasive approach to traditionally open surgical procedures. Now, benefits of lap and robot is the advantages of MIS, that is reduced morbidity, hospital stay, faster recovery, and improved cost messes. The challenges that are there in laparoscopy is that it is often associated with the steep learning curve as opposed to robot. There is complex anatomy that we need to understand while doing reconstruction, and there is a need for advanced suturing skills. Now, the bottom line principles for any reconstructive surgery is, of course, tension-free anastomosis with an adequate blood supply and watertight closure. Success often depends on the etiology of the stricture, the length and the location of the stricture, and the factors that affect the outcome. Of course, again, the surgeon's experience is there, patient selection, the etiology or the pathology is there, and therefore there is a learning curve as far as surgeon is considered. So we need to do 20-30 cases of laparoscopic pyeloplasty before we can start doing complex procedures, reconstruction in a step ladder fashion, and gradually ascend the learning curve while we do difficult procedures later on. Now, most reconstructive procedures aim to maintain the continuity of the urinary tract. The upper tract laparoscopy general procedure is steep lateral position, whereas for lower tract it is steep Trendelenburg position. Suturing skills and knowledge with sutures is essential. And as far as sutures are concerned, we know there are 3 sutures which are commonly available. That is Vicryl, this is polyglactin, then the monocryl, that is again monofilament absorbable sutures, and the PDS, which is polydiaxanone. So as a general rule, when you do in pediatric surgery, you consider using PDS, but problem with the PDS is sometimes it is difficult to handle and not tying due to high memory, and therefore you use in the smaller suture are easier to handle rather than the bigger suture. So if you had to handle 3040, it's slightly difficult. 4050 is better. Otherwise, in general, you can use Vicryl sutures. Now, key applications as far as reconstruction of urinary tract will start from upper tract and then proceed gradually to the lower tract. So again, the key step is again mobilization. And when we are doing mobilization for reconstructive surgery, what we have to remember is that mobilization of the ureter has to be limited, whereas you can do the mobilization of the kidney. So here you can see we are doing reconstructive surgery for a redo pyeloplasty procedure, and the pelvis is almost intrarenal. So when you do mobilization and you are thinking that the things are not going to come close apart, you can do renal descensus, dissect out the kidney. And some cases you have to start preparing for plan B, that is in some cases where the approximation is not adequate, then you will have to do ureterocalycostomy. So as a part of general mobilization of the kidney, you keep on dissecting out the kidney lateral side, upper side, on the medial aspect. And when we do complete mobilization, as you can see, the kidney starts falling down, and you can get an additional 2 centimeters of the mobilization. So once you cut across, the spatulation again in the ureter is on the lateral aspect, and when you cut across the stricture, then the spatulation on the kidney is on the lateral aspect. Now, once you have done adequate mobilization, you will find surprisingly that in those cases where you feel that the approximation will be easy, will be difficult, with sutures it will come out proximally well. So one technique again is to hold 2 sutures apart in the uterus, because if you apply suture with a single suture in the ureter and tie up, and if there is some traction, it may cut through. So it's better to use 2 sutures. So here you can see it is getting approximated. Now, in certain cases where you have to anticipate that the pelvis is intrarenal and there is a thick cortex, this was the case where the kidney is functioning around 20% and the cortex was thick. So you have to plan ureterocalicoscopy. And when you plan ureterocalicoscopy, when the cortex is thick, I do it under warm ischemia, apply a bulldog clip, chop off the lower pole of the kidney, and then do everting sutures, which goes through the urothelium and the cortex. So these are everting sutures, 6 to 7 the everting sutures will help you evert the mucosa. Once you have applied the everting sutures, you can release the bulldog clamp, so the kidney is vascularized again. And then the same process, lateral spatulation of the ureter, and then anastomosis to the lower pole of the kidney, making sure that your urothelium to urothelium anastomosis is there. So there is urothelium inside the kidney, and then the urothelium in the ureter. So again, if you think that the vascularity is an issue, you can take interrupted sutures. 6 to 7 interrupted sutures will help you to complete the anastomosis. You can also take continuous sutures if the tissues are not in tension and the vascularity is good. So this is again CT IVP of the same picture, showing good drainage at the end of 1 year, and kidney which was around 20% functioning is still functioning. Now this happens when the tissues are not enough, but sometimes there is tissues which can be taken from the kidney, like this case where we are planning for a pyeloplasty, and you can see there is a long segment stricture in the upper ureter. So when you have to bridge a gap of long segment ureteric strictures, you have to take flap from the pelvis. So this is vertical scardinoprints flap that we are taking from the kidney. So here we do not dismember the ureter, whereas we take the ureterotomy on the anterior surface of ureter, go up into the pelvis, and the length of the stricture is measured, and the same flap is created from the kidney. So now you can see the flap of the kidney is being anastomosed with the normal ureter. The posterior layer of the flap pyeloplasty being done in a continuous manner. Here you can see I am using PDS suture, 50 pediatric PDS suture, because the child was 9-year-old child. And then once you complete the posterior layer, then you can place a DJ stent and close the defect anteriorly over a DJ stent. So this this will bring out some flap from the kidney and can bridge the gap for the continued. So whatever reconstructive procedure that I'm showing is for complete strictures. For partial strictures, you can take use of buccal mucosal graft to similarly bridge the gap. Now coming down in the mid-ureter, you need to have some kind of grafts. Either you can take buccal mucosal graft if you think it is a partial stricture, or you can use local grafts. Now the local grafts are Monty ureter for the left side. So here you can see I have dissected the kidney. Now the gap which is there is around 8 centimeter. So I take a bowel segment, take 2.5 centimeter ileal segment, detubularize it, and then anastomose on the corresponding opposite side. So with 2.5 centimeter of ileum, you get around 6 to 8 centimeter of the conduit that you can prepare, which is called as Monty. If the stricture length is more than 6 centimeters, then you can take double Monty. So the Monty is replaced in the bladder. It is placed behind the sigmoid colon if you are doing it on the left side. So here you can see, the bowel mesentery. You make sure that it is not twisting. And the Monty ileal ureter is then anastomosed with the strictures normal ureter on the superior aspect. I fast forwarded it because the time limit constraint of 20 minutes I have to show entire range. So here you can see the Monty segment being anastomosed with the upper ureter and the lower ureter. And this is the RGP, which was done 6 months after the procedure, diagnostic ureteroscopy, which reveals an open Monty segment. Now, if the defect is on the right side, you can utilize appendix. And appendix can be utilized either as a tubular graft or as an onlay patch. This is the segment of the ureter on the right side. So this, again, the segment of the ureter is excised. Once the segment of ureter is excised, then you again measure the gap, and then you can use the appendix. Now, the important point, I was seeing Dr. Gau's video yesterday, but there is a difference of the technique that I do with what he showed. I anastomose the normal base of the appendix first. So the anastomosis is done from the base of the appendix. So unlike the previous case where the anastomosis was done from the upper ureter, I started from the lower ureter. And this is the base of the appendix being utilized for the anastomosis with the ureter. Once the base of the appendix is done, then I pass a ureter catheter into the lumen of the appendix and select the segment of the appendix that has to be used to bridge the gap and excise the rest of the appendix. So excising the tip of the appendix up to the segment of the appendix which is not required is all right. But if you leave alone in the base, then it will be a stump which is not to be removed, because it is supplied by the mesoappendix. Similarly, if there is a partial stricture and you are planning to do appendiceal usage, then you can use it as a partial patch also. You can detubulize the appendix and then put the appendix on the stricture side. So this is the complete repair of the stricture on the right side with the use of appendix. Now there have been local grafts also. So this is an interesting case, which was a 45-year-old female and had a history of URS. Then she developed ureteric stricture, and the ureteric strictures are unique in the sense that she had developed two strictures. So you can see there is one stricture in the upper ureter, and there is lower ureteric stricture. With the mid ureter was normal. So mid ureter is normal. There is a small stricture in the upper ureter and the lower ureter. So I've tried to use the middle ureter as a conduit again, excising the stricture segment in the upper ureter, and then making sure that you dissect the lateral aspect of the mid ureter which you are planning to use as a conduit, not dissect out the medial ureter where it receives the vascularity. So here you can see isolation and dissection of the ureter is being done at the lower segment. And then the end-to-end anastomosis of the upper ureter, that is in end-to-end manner, can be done. So you can see the vascularity is good of the mid-ureteric segment, which is still receiving blood supply from the medial aspect. So you have bridged the gap of the upper ureter by doing an end-to-end anastomosis. And then for the lower ureter, you can use a Bowery flap, close the cystotomy. This was done in Trendelenburg position. And then this patient is again subsequently turned into left lateral position, and then the lower end of the ureter is anastomosed with the Bowery. So in fact, you have used this mid-ureter, normal mid-ureter as a graft, which is obviously better than using a patch of buccal mucosal graft, and the patient had good outcome. Now coming down to the lower ureter, it's always easy to use bladder flaps. So when you want to bridge the gap in the lower ureter, you have to make a flap from the bladder. The bladder is taken down. This is done in steep Trendelenburg position. And the unique points of taking bladder flap is that it has to be wide based. The apex to the length of the flap should be more than 3:1. So you have to take a triangular flap, mark it out on the superior surface of the bladder. This we do when the bladder is already full with saline. And then the marking is done. Once the marking is done, the bladder is cut open, cystotomy is done. I use hook just to prevent the excessive loss of the blood, and it does not make a difference. So once the bladder flap is done, the base of the flap is extended laterally so that the base of the flap is wide, and it can bridge the gap up to the mid-ureter very easily. So from mid-ureter to lower ureter, the options that you can use is either do ureteric reimplant if it is in the lower ureter, or you can use Bowery flap depending upon the length you want to use to gap the mid-ureter. Now, extending this, we can also use Bowery flap for upper ureteric stricture. So this is a scenario where we use Bowery flap for upper ureteric stricture. The difference here is that we take a spiral flap starting at the apex of the prostate. Position is done in two positions, lateral positions for the upper tract and steep Trendelenburg position for the lower tract. So this was a case which had a long upper ureteric stricture. So you can see the stricture segment being cut open, and this is the gap that we want to cover. So once you cut open the ureter, again to gain additional 2 centimeters, you do renal descensus, and then you make a spiral flap. So you can see on the left side is the apex, and you take out a small triangular flap which is round at the apex, then make a trapezoid base flap. This is the trapezoid base flap, and then you are widening the base. So in essence, this is a trapezoid base flap, which the apex goes into the upper ureter. So this apex that we cut here will go into the upper ureter, whereas the trapezoid mid base and the base will cover up the mid and lower ureter. So that is the trapezoid base flap. Here we want to ensure that we don't ligate the superior vesical pedicle, because it's a long flap and you want to maintain the vascularity which goes into the upper ureter. So the cystotomy is closed in Trendelenburg position, and this is the flap which reaches the upper ureter. You change the position into the steep lateral position, and the apex of the flap is then anastomosed with the stricture in the upper ureter. So here you can see it is very easily reaching the upper ureter. So once you do it, you place a DJ stent and then close. So this shows that the Bory flap can reach the upper ureter very easily, and this is the CT IVP of this patient taken 3 months back after removing the DJ stent. It's a short 10 mm and 5 mm 2 ports and 1 10 mm ports in the umbilicus. You can complete the entire procedure for stricture in the upper ureter. Now, sometimes there are unique conditions which require some special situations, like ectopic kidney, secondary PUJ. So these are the conditions where again some difficult laparoscopic surgery is anticipated. Procedure is carried out in steep Trendelenburg position. You dissect out the kidney, but because of the adhesions in case of secondary PUJ obstruction, the anastomosis and the dissection is difficult. So here I am trying to dissect out the ureter. Once I dissect out the ureter, I trace it proximally to reach into the upper ureter. So this is the ureter and the pelvis. There were secondary stones in the pelvis that were removed. And then the pelvis is opened up. So what we do here is we do a pylovesicostomy. How we do it? We make tubularized pelvis. So pelvis is excised, and this is the tubularization of the pelvis that we are doing. The pelvis is tubularized like this. So with V-lock sutures, 20 V-lock sutures, we can tubularize it, and the lower end of the pelvis is opened up like a funnel. So here you can see the lower end of the pelvis being opened up like a funnel. Then we dissect down the bladder, take a psoas hitch to make sure that the apex of the bladder reaches very well up to the opened up of the pylotomy. So this is the psoas hitch being taken up and the bladder being approximated to the open end of the psoas. Now the funnel shape of the pelvis is anastomosed to the neocystotomy side. So here you can see when we do a vertical incision and we anastomose, it becomes a long tubular structure. So here the apex of the pylotomy is anastomosed to the neocystostomy. So once it is stretched up, you can see the posterior layer of the pelvis opens up like a ureter. So, and then this is with a stent being placed, so this becomes a new ureter to the pelvis. So there is a pelvis and there is a new ureter, and then that opens directly into the bladder. So once the posterior layer is completed, then the tubularization process of this new ureter is completed, and we complete the entire procedure laparoscopically. So this is a very important and a very safe salvage procedure for patients who have ectopic kidney and have failed reconstruction priorly, and then the bladder is closed. Now you can do all laparoscopy into a challenge. You can challenge yourself. So what we do is for pediatric patients, we do not use the normal forceps. We do mini lap procedures where we use 5 mm camera port and 2 3 mm ports. So with 5 mm and 3 mm ports, we can do the entire reconstruction, especially in pediatric patients. So this is case where I was doing ureteric reimplant and anti-reflux ureteric reimplant. So you can see we can dissect out the ureter, separate out the submucosal tunnel, and then make a neocystotomy at the anterior end, cut the ureter. So this procedure is, the only limitation is that you get a 5 mm, your circular vision that you get. It's not the 10 mm vision that we are getting with mini lap procedures. So interrupted 6 sutures are taken at the distal end of the ureter, and then a modified Lich-Grigor technique is used to cover up the detrusor raphe. So here you can see the neocystotomy being made, and then the suture is taken out in the anterior surface of the bladder just to re-advance the ureter, what we do in transplant like modified Rich Gregoire, and then you cover up the tunnel and make it an anti-reflux procedure. So the procedure is done just by, and this procedure is slightly tricky because you are doing it with 3 mm instruments and 5 mm camera port. So this maintains, this is one procedure I think is where robot is still not able to compete, because we are completing this procedure with 5 mm, 3 mm. Similarly, the same procedure you can do ureteric tapering also. So this is a case where primary obstructive mega ureter was there, and with 5 mm, 3 mm we are doing ureteric tapering and completing the entire procedure. So this is the tapering part. Then the next part is suturing the lower ureter in a continuous manner proximally and taking 3-4 interrupted sutures on the distal aspect. And this is the final picture that we get with mini lap procedures. So as far as the functional outcomes are considered, they are comparable to open surgery across most procedures. Quality of life is significantly improved with minimally invasive approach. Robotic assistance may shorten learning curve for intracorporeal suturing. That is the only advantage that I see. Long-term durability, almost 10-year success rate in cases of redo pyeloplasty are reported to be more than 85%. So for all difficult reconstructive procedure, it's the procedure of choice. Future directions, enhanced imaging, improved instrumentation, and AI-assisted surgery is of course coming into picture. We have expanding application. You can do ureterocystoplasty, you can do augmentation cystoplasty, continent diversions, all with laparoscopic approach. And training with simulation programs, fellowship programs, proctorship is essential for skill development. So just to conclude in a humorous way, I can say that when robot came into picture, there was a issue of master and slave. So in this era, master was considered to be the console where the surgeon was sitting for doing comfortable procedures, and the slave was the one which was near to the patient. But as I see, because since I am an entrepreneur, if I want to purchase a robot, I have to invest money. So I can see that the master is not the one which we are thinking. Master is the company which is marketing robot, and slaves are obviously we are the slaves. So, and when we speak among the slaves, so we ask, how is your slavery going on? So he says, no, I am doing in a console. The other person is saying, no, the master has not given me console. I am seeing in an open console. So we are fighting among the slaves. And who is gaining? It's the master. So all is driven by economics. If you see this, it's all minimally invasive surgery. All meta-analysis that have been published have not demonstrated superiority of robot over lap, provided you are expert in lap. And if you become an expert in lap, you can justify the same procedure. We are still, there are so much population living in poverty, both in India as well as in this part of world. So if you have to offer this surgery, you have to master yourself rather than doing slavery. So this is my take-home message. Thank you so much.
Thank you, Dr. Mishra. You wonderfully presented the complex surgeries. And of course, what you have said is very right. But it requires a lot of training. Laparoscopy, why people are now going away is because of the training. Once you have trained and once you have spent time, once you have done hard work, then as he rightly pointed out, the robot and laparoscopy, I don't think there is any difference. Any questions, comments? Any questions?
Only the comments. Like you said, definitely in a finance crunch situations, like in a country, third world country or developing country, people are not, they are not accessible to robot. Either surgeons are not accessible or the patients are not accessible. So there, the laparoscopy definitely comes. But once you start doing the robot, the other way around, you'll forget laparoscopy. That is also true.
So this is the message I want to give. Don't forget lap.
Okay, now what laparoscopy, what robotic surgery has done? Yes, sir, please. Basically what robot has done is that he has brought 20 years person who has spent time and learned, he has brought down to equivalent to a person who has spent only 1 year. So 20 years to 1 year, that is what robot has done.
At the
But
cost
a
of-
person who has spent 20 years will remain always at the top.
My small query is, what is the cause behind why 85% success rate only for 10 years?
No, this is redo pyeloplasty. I was talking about redo pyeloplasty cases. So redo pyeloplasty cases, actually, they are all salvage procedures. Primary pyeloplasty success rate is more than 98%. But in redo pyeloplasty, because of the restricture rates, the length of the stricture, the duration of the stricture, and the function of the kidney, all are compromised. So for redo pyeloplasty, that rate is always inferior than the primary pyeloplasty.
Thank you, Dr. Mishra.
Thank you, sir.
We go ahead with the next one.
The next presenter is Dr. Lee Jiong Ming. He will be giving us the tips for laparoscopic radical prostatectomy and protection of continence mechanisms. Again, this is another surgery where robot has got the maximum utility.
But it gets further. The plate is, which one? Okay. Good afternoon, everybody. Thank you, UROCON, Dr. Ba, for your invitation. So I have this opportunity to come to the very beautiful city, Bokra. Today, I'd like to introduce my some clinical practice in laparoscopic radical prostatectomy. My topic is tips of laparoscopic radical prostatectomy. But everybody knows with the advancement of technology and equipment, laparoscopic and robotic assisted laparoscopic radical prostatectomy have become the main method for surgical treatment of prostate cancer. But however, how to reduce the complications and achieve the goal of tumor-free, bed continence, and sexual function protection is still a challenge for every doctor. Especially for young doctor, the radical prostatectomy is a complex procedure. If you want to master this procedure, you should know the every main surgical step and learn it step by step. Following is our key surgical step, and the tips I will explain it by video. But during operation, we have to pay attention to protect the continence tissue, which includes external sphincter, bladder neck muscle, internal sphincter, and the pelvic fascia, levator, and muscle, and the periurethral muscle group. Let's see the video. It's laparoscopic surgery. No. Play it, person. Okay. But our first step, we should make a retropubic space and remove the fat pad around the prostate and the bladder neck. And then we cut into pelvic fascia and expose the complex DVC. Here is a cut in the pelvic fascia. Okay, here we should preserve the levator and muscle. It's important for continence after operation. Suture and navigate the DVC. It's important. It's very important to reduce bleeding loss. And then we should look for bladder neck. So we can find the border prostate and bladder neck at the end of bladder muscle. And transect bladder neck vertically. It's important vertically, okay. Sometimes we can, if you contract obliquely, so you will into the prostate. So we have to transect vertically here between the prostate and bladder neck. So here we can find the bladder neck, okay. But now we continue to cut the tissue around the urethra. And expose the urethra and cut the bladder neck. In this step, we have to preserve more bladder neck muscle. It's very important for continence after operation. And then strict transect tissue and look for the vestibular and semivesical and divide these organs. We always, before the cut, but definitely always use homolog. Okay, here is separate and dissect the seminal vesicle. This area is a vesicular pedicle of prostate. We should cut it near the prostate and preserve more endopelvic fascia. Okay, when we free the posterior wall, we should announce the denovidius fascia. Okay, it's a good space. It can avoid to injury the rectum. But the last step is cut DBC and expose the urethra and the urethra group muscle group. Keep more external fixture and urethral muscle group. Now remove prostate. The last step is anastomosis, bladder neck, and posterior urethra. But in my habit, we always use double leader and have purchase suture. The total suture is about, stitches is about 12 in our patient. 12 is a normal suture. But so after anastomosis, we should inject liquid into a flange and check the leakage. But in my operation, I have to insurance no leakage for every case. But after suture, we always suspend the urethra and suture at the retropubic bone. Okay. Let's close the retroperitoneum. Okay. Inject liquid, no any leakage. It's a robotic surgery. But in my cases, robotic surgery and laparoscopic surgery is have to have. But in our hospital, I always do the robotic surgery. But in other hospital, because many hospitals don't have robotic. But in our hospital's cases, I use laparoscopic surgery. But in my opinion, it's same. The same outcome, same continence, but the laparoscopic has his advantage because equipment is cheaper. But since finder thing, interesting thing, our doctor always think robotic. But in my opinion, the step, the laparoscopic surgery is very, very important, basic. If we have a good laparoscopic basic, when you use a robotic, it's very convenient, very easy. So I always emphasize the laparoscopic surgery is very important for every young doctor. Here is exposed bladder neck. And in this step, we always emphasize we should preserve more internal sphincter, means bladder muscle. Okay. But it's same step, same step and method as laparoscopic surgery. But I find the robotic, the main advancement is reconstruction. Just to cut and remove tissue, maybe laparoscopic use has his advancement. Okay. Here is culture pedicle, vascular pedicle near the prostate. Free posterior wall around the denervation fascia. Denervarius fascia is important anatomic plan. Preserve a small periurethral muscle group is important for continence. Okay, the last step is anastomosis. But the same way to anastomose bladder neck and urethra. But in robotic surgery, it's more convenient for anastomosis. Okay, the same way. But in all cases, if we preserve the more endopelvic fascia, so after anastomosis, we should reconstruct endopelvic fascia. For this patient, we give a patient reconstruction of a posterior wall. But suspend the urethra. But reconstruct endopelvic fascia. But not every case, but some cases if we have more endopelvic fascia preservation, so we can reconstruct it. But from the report is benefit to the continence. Let's see. But let's see the catheter removal time. In all cases, the catheter was removed in 5 days after operations. But before removing catheter, cystography is necessary to elevate anatomic leakage. Let's see the continence, but it's recent. Our case is the total is 112. 2 weeks continence 56%. 1 month is 82. 3 months is 93. 6 months is 97. At 12 months is 1990. But just one patient after 1 year, the patient every day should use one pad. Thank you very much. But next, I'd like to introduce our Golden Bridge International Urology. Welcome to this conference, which will be held in 12th to 13 September this year in beautiful city, Lijiang. Now, but if you are interested in this conference, if you want to know more detail, please contact my student, Proshan. He is my foreign secretary. That let me see you. Lijiang is a very famous city in the world. There's lots of different scenery, such as snow mountain, lake, river, ancient city, and multicultural. It's a very interesting city. I hope everybody have an opportunity to visit there. Welcome. Thank you very much. Very beautiful scenery. Okay, it's our ancient town.
Thank you, Prof. Li Zhong, for sharing your excellent videos on laparoscopic versus robotic approaches to the prostate and your techniques in terms of improving continence. I think this is not a question, this is just a comment. You know, I think you're probably one of the few people who I enjoy watching laparoscopic radical prostatectomy because you make it look almost as good, if not better, than robotics. So it's wonderful watching you do particularly things like those urethrovesical anastomosis, very meticulous, even laparoscopically. So it takes a lot of skill and a lot of experience. Thank you, sir.
Thank you.
Any comments, any questions from the floor? Is translating. So the question relates to early removal. Early removal after cystogram shows no leak.
It's a very good question. But in our case, it's remove the case in 5 to 7. But I see some report. But in the many reports, but the remove time is 3 to 7. It's common in the world. But if you preserve pronounce the catheter, but it causes urinary infection, and it will influence continence recovery. Thank you.
Actually, you are using the burp sutures, and on table you see the leak test. So if there is no leakage on table, it was easy anastomosis, and you are using continuous burp suture. It's not interrupted suture. Say, for example, when you go for open radical prostatectomy, you used to give an interrupted suture. There, it was mandatory to keep it for minimum of 2 weeks. But here, 5 to 7 is good enough.
Okay. Thank you.
Okay.
So next up, we have Dr. Rikesh Karki, who's talking about the pioneering journey, evolution of laparoscopic urosurgery at BBK IHS.
Good morning. Myself, Dr. Rikesh Zankarki, Associate Professor Urology, BPKS. Right now I'm in charge of Urology Division. My topic today is the pioneering journey, evolution of laparoscopy urosurgery at BP Koiralat. We just want to show how we transition ourselves from open to laparoscopy first standards. The foundation data I have taken, the publication by Dr. Ram Sagar Saha and Professor C.S. Agarwal, our retrospective study of nephrectomy done at BP Koirala Institute in 2017. This to show the scientific control group to see how we progress ourselves in laparoscopic surgery in later days. And in the outset, I'd like to thank Professor C.S. Agarwal, sir, very much for he was the one who encouraged us really to leap forward in laparoscopic surgery. So thank you very much, sir. Surgical strategy open approach, it was subcostal flank incision used to be at that time. And median hospital stay according to that report is 8.5 days. And high volume proficiency of BPKHs in open surgery at that time used to be the center of excellence, necessitating for minimal invasive surgery. So timeline, transition decades from 2014 to 2024, we have collected data of almost 296 open nephrectomies. In early phase 2014 to 2018-80, we were still in open standard. A few laparoscopic surgery from visiting faculties. In this outset, I also like to thank Dr. Ravinder Sabni sir, Sasikan sir, Ganpule sir, Lee Chiaoming, so many faculties, Malikarjun sir. In the recent history, recently, Dr. Pukar Maske sir, he also visited to our institute and to help us and also to encourage us in leaping forward in laparoscopic surgery. Thank you, sir. So evolution of inflection in 2018 to 2023, aid introduction of laparoscopy, simple nephrectomy, and deroofing. The strategy adoption, actually laparoscopic first concept we started from 2023 to 25 onward, almost like more than 50 simple nephrectomies in this time. The department moved away from traditional open first approach. So program successfully expanded from foundational simple nephrectomies to complex oncology procedures like radical prostatectomy and radical cystectomy. So hybrid strategy that we have approached right now, this is to complex pelvic reconstruction, allowed laparoscopic oncological resection combined with planned open reconstruction to ensure patient safety and optimal outcome during the transition. So here in this picture you can see time, pain, and all these things. Now we relax, conscious seditions, and listen to the music. And here the result is so many small dots like incision, and you can also deform and meaty patient. You can join all this incision to make one scar that we used to do in open era. So easy way out, we started with laparoscopic cyst deroofing. Now resident days usually start with this case in our institute. So clinical audit, laparoscopic simple nephrectomy 2020-25, almost more than 50 cases we have done. And mean hospital stays 3.24 days, that almost significantly reduced in 8.5 days in open era. Evolution of radical nephrectomy, this 2-3 years we have almost done like 11 cases of radical nephrectomy. Currently we have a strategy of going for T1 and T2 directly laparoscopically. And in high, like T3, we plan accordingly. So clinical outcome versus literature is almost similar in our setting. So use of advanced energy source like harmonics, ligaseous, and hemologs has reduced mean operative time and estimated blood loss compared to early institutional open series. So these are the Excel sheet of the cases of radical nephrectomy. So learning curve significantly in 2020 used to take more than 5, 6, 7 hours, and we always have problem with anesthesia for converting. But we consistently went ahead, and now it would take like 1.5 to 2.5 hours for completing the procedure. Overall, there was one case for conversion. So length of hospital stay has drastically improved. So here I just want to show the case discussion for one case. Actually, it's a huge mass seen in the CT scan. We stayed in the console with radiographer, and interestingly, we had planned to open this case, but there was only one vessel, single vessel hanging in the upper pole region with renal vein free, artery free. Only so much of collaterals making it very dangerous. But we attempted with laparoscopically, and we could successfully did this case, and in provisional report I have not got, but as heard this is margin free with chromophobe in a histopath. So another is lap nephrectomy. We have not done much, but this is 2 cases this year with hybrid approach converted for bladder cuff excision, and hospital day was not more than 5 days. Reconstructively, we have been doing pyeloplasty regularly. And nephron sparing surgery, partial nephrectomy, in series, I just want to discuss one case which we have learned lesson. This is case discussion of 72 years female from Japa, non-smoker, politician, came with hematuria, all investigation within normal, CT scan, showed 4 centimeter exophytic left lower pole enhancing mass. And in this outside, you can see the mass in the very simple looking mass and perfect. We thought like, okay, let's go for lap partial nephrectomy. So hilum was dissected well, and we 3 brothers in arms, we are doing very relaxed mood, doing this scan, but it was taking so long time dissecting, and we thought, because we don't have a laparoscopic ultrasound with us, so when we were dissecting off the tumor, we thought we have to again clear off the margin, and we again revised the margin, and it took more than 5-6 hours. So here is a little bit video clip of how we dissected it was very simple looking single vein, and no lumbar vein or gonadal vein in front of us, and single artery, and nothing was seems to disturb us. And later on we started, after clamping, warm ischemia time started, and we started dissecting the tumor. Because these are our early cases, so we're not so much comfortable like experts we heard like Shashikant sir and Licha Ming sir, but still we tried our best, and we achieved the case. And histopath came out to be the tumor tissues shows renal parenchyma, fibrofatty tissues all were free of tumor, and even the margin which we again cut off and sent for histopathology was free of tumor. But after 28 days, patient came back with gross hematuria. And it was our early cases, so still we thought we have to manage this case. And we did CT angio, and there was CT 3D construction showed this angiography, and pseudoaneurysm was there, and selective embolization was done, and luckily patient did well and discharged the patient. And later on, we did renal Doppler after this. Renal Doppler was okay. So we may have to wait to see DTPS scan after a few months how her kidney is doing. So advanced pelvic oncology laparoscopic radical prostatectomy in 2025, we have done 2 cases this year. Laparoscopic pelvic dissection, 1 case laparoscopically completed the case, but another one we have to open for anastomosis because it was taking too long time, and suturing skill we still have to develop. So in discussion, I just want to discuss one case, 68 years, male patient who had undergone TURP 3 years back. Everything was normal. He lost his histopath report, and PSAs were normal. He came to us with bladder neck contracture. We did bladder neck release and selective TURP. Report came to be adenocarcinoma, and all PSMA and everything we did. Final report came, and we did laparoscopic radical prostatectomy in his case. And final report came out to be adenocarcinoma, Gleason score 7 and grade 2. Hybrid approach, now we are doing at least 2 cases this year, radical cystectomy. The hybrid approach, we had laparoscopic radical cystectomy with pelvic dissection, and open part with pelvic lymphadenectomy and ileal conduit. And just want to discuss in this case, 34 years male, non-smoker, left. Lost to follow-up 3 years before we had done TURP on him, and he came with all bladder full of tumor, and CT scan showed this almost perivesical space, and lymph nodes were involved, and 4 cycles of GEMS cyst was given to neoadjuvant was given to him. When the tumor was regressed, we approached for hybrid laparoscopic radical prostatectomy with open ileal conduit. And this is the case. And final report, PT2B, tumor inverse deep muscularis propria, outer half, and the single lymph node in true pelvis was seen. In conclusion, BPKS has successfully crossed the decade breeze from open to laparoscopic standards. Future goal is 2026 is intracorporeal ileal conduit, creating neobladder, increasing volume of nephron surgery. And I always tell my resident that there is always a long way to go. Someone is born always. So if people who are seniors, they're doing very high-fi surgeries and all this thing, we have to move ahead with a simple ladder. I think we will be successful one day to reach, because the time gap between the first laparoscopic nephrectomy and here, maybe 10, 12 years down the line. So we may one day catch up. So thank you, anesthesia, oncology, cardiology, radiology, MIS, urology, whole BPKS team for helping us in this laparoscopic surgery. And we just recently had operative workshop in laparoscopic. Thank you everybody who attended. And special thank to Sapni sir. He is always encouraging us and always there to support our academically. Thank you very much.
All right, thank you very much. I think I must congratulate you for bringing up the laparoscopy and doing so well in Taran. Thank you.
Thank you, sir.
Congratulations, Ritesh. I'm very happy that we all are taking this path from difficult path, actually. Initially, when I started laparoscopy about 10 years plus, I used to ask myself why I am doing it. I'll do open, I finish in like 45 minutes. Why I'm doing all this struggle for a few hours. Now I ask myself why I was doing open now, because it becomes more easier more you do it. And one small query that why did you choose to do lymph node dissection by open method rather than laparoscopically?
Because it time taken for us to do cystectomy was already crossed.
But I tell you, laparoscopically lymph node dissection much
we
more
were
faster.
Advancing, but we thought it will become so late and
I know.
we have to also think
I know you're so tired.
Yes.
So because the view is so good,
yes.
It's much more easier in laparoscopy. Yes. Thank you.
We will try. Thank you, sir. Thank you for your advice. Thank you, sir.
Thank you, Rikesh, for congratulations for doing a very good work in BPKIS. I just want to remind that the laparoscopy started in Nepal when the North Zone India, we organized a live workshop in Donikal. The North Zone of India, we organized around 4 cases. We were only watching, thinking that when are we starting this? So another 12 years our journey, almost all the hospitals now doing the laparoscopic procedures, including cystectomy, prostatectomy, all the major cases. I think we hardly see open cases these days. Regarding a large, renal mass, and then sometimes what I do is everything mobilized laparoscopically, make a small incision and do a partial nephrectomy. That way you don't have a robot and things, even laparoscopically also. That will also decrease the morbidity so much. Even 8-9 centimeter tumors, I have managed to, mobilize completely, laparoscopically, get hold of the vessels, and then make a small incision there. It's very easy. You can rapidly suture the kidney. So that way also you can manage a big renal mass. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you, Rikesh, for your nice presentation. I would like to congratulate you for your presentation, and I hope that under your leadership, the Department of Urology or Division of Urology will grow further, and you will achieve your goal in 2026. Best of luck to you. Thank you.
Thank you, sir. Thank you, sir.
May I request Dr. Deepak Thakur for the next presentation, and he is going to talk about step-by-step laparoscopic nephrectomy and the key operative steps and technical pearls. Top Urology, Virat Medical College, Teaching Hospital.
Good afternoon, respected chairperson and ladies and gentlemen. I am given the topic of laparoscopic nephrectomy step by step. I have nothing to disclose. The learning objective of this presentation will be to know the indication and contraindication of laparoscopic renal surgery, correct patient positioning and OR setup, as well as stepwise operative procedure and technical faults and pitfalls. So, laparoscopic nephrectomy is indicated, or be it open or laparoscopy, it is indicated for the non-functioning kidney. Other than that, it is indicated in functioning kidney also, like that we are doing for the renal tumors, localized renal tumors, and during the donor nephrectomy. And it is contraindicated in uncorrected coagulopathy and those patients who has poor cardiopulmonary compromise. And relatively, it can be contraindicated if you don't have expertise, those patients with prior abdominal surgeries, morbid obesity, or large renal mass, more than T2 involving hilar region, you should avoid. So patients should be evaluated as per the institutional protocol, and that includes lab and contrast CT. And in contrast CT, especially you have to look for the accessory or aberrant renal vessels, and bowel preparation is optional. You use prophylactic antibiotic as per your institutional protocol, and especially when you are beginning and you are beginner, you have to have blood products arranged. And also you should consent and explain the patient for possibility of conversion and have conversion set prepared for you. So it is done basically in the flank position, and such that the space between the rib cage and iliac crest increase, and arms should be stabilized, all pressure points should be padded, and patients should be secured on the operating table. Anesthesia is generally preferred general anesthesia, and the approach can be transperitoneal or retroperitoneal, and for the beginners, we follow transperitoneal approach. Pneumoperitoneum, you can create openly or closed. We prefer closed one. And ports, 3 or 4 ports are required, as depicted in this picture, but the camera port and working ports should triangulate at the hilum with 6 to 7 centimeter distance between each port, such that there will be no clashing of instrument during your procedure. Here I am representing one of the cases for which we did transperitoneal nephrectomy in a upper benign conditions. She was a 52-year-old female who had history of left flank pain for the last 3 years. She was hypertensive. She did not have any prior intervention. She was evaluated, and her CT scan shows left-sided grossly hydronephrotic, non-excreting kidney with distal ureteric stone. On DTPA scan, her left-sided kidney was hardly 13% functioning. So it was decided for the lap nephrectomy. So when you enter in the abdominal cavity, these sorts of lesions are common. So you have to release this sedation meticulously, taking tissue bit by bit, taking care not to injure the colon. The incision has been released, and now we are mobilizing the colon. We prefer the just lateral to the fat, colonic fat. You can recognize the thick colonic fat here in this picture. The colon is being taken down, exposing the hilum. Since it's a hydronephrotic kidney, we did some decompression here. Now, after creating 2 windows, both proximally and distally, now the ureter is being mobilized and divided. Now we have already isolated the vein, renal vein and renal artery. The artery is being clipped. And it's being divided. Now the vein is being lifted. It's being prepared for clipping. Now it's being divided. Since it was a benign condition and fat between the aorta and adrenal is being preserved, so we are preserving adrenal here. Now the only lateral attachments are left. That is being released. Now the kidney is ready for delivery. We are checking for hemostasis. And drain is being kept. This was a post-operative picture. So my take-home message for the beginners is, when you are selecting laparoscopic renal surgery, you have to select cases properly. Try to select hydronephrotic, non-infected cases first. And if you can position the patient properly, you will have edge in working onwards. And you must have some gadgets, especially energy sources. And when you are dissecting, you have to follow certain patterns. You should not haphazardly do haphazard dissection. And of course, you have to create double window around the hilum before mobilizing and ligating the vascular pedicles. And of course, you should not hesitate. If extra help is available, do take it. And you should not hesitate to convert also. Thank you.
Thank you for the nice presentation. I just want to know extraction of a specimen.
Already I have shown in the incision.
I
use
didn't
one
get
of the
it.
port. and extended it, and it was.
And so my suggestion is next time you take it out to the iliac fossa. So then that wound also will be hidden. That we call it a beginning incision.
So since it was a hydronephrotic kidney, a small mouth, that's why we use the same.
You suck out everything, it will be very small, and you can take it out to the iliac fossa incision.
Thank you, sir.
And I just have a small, it's a rather suggestion. I saw that you cut the ureter out before even reaching the hilum.
No.
I always cut the ureter at the end because with that you will have some kind of traction down here when you are lifting up the kidney, and it is much more easier. Sometimes what happens, if you cut out the kidney, it will be relaxed and it keep on coming up, and it may not be easy to, to go to hilum.
Since this is an edited video, so I could not demonstrate, or maybe I could not demonstrate all the steps properly, but once I create double window around the hilum, then I divide ureter, and then only ligate vessel.
Okay. Thank you.
Yeah. No, I said bowel preparation is optional depending upon the case. For this sort of benign cases, we are not going to prepare. But large tumors, then it may be option for you. Even putting nasogastric tube also is option for you. Yeah. So you have seen the CT images also. There is hardly any renal parenchyma, and there is hardly any enhancement or excretion. So you correlate radiological finding with isotope scans. Even for this patient, even there was some parenchyma, I would have gone for the stone surgery rather than the removing kidney. But if you see the CT, there is hardly any parenchyma.
Okay, thank you. I think we should.
By Dr. Birendra D.K. Pal, D.K. Rai. He is going to talk on laparoscopic partial nephrectomy made simple, tips and tricks and technical pearls. Please go ahead.
Good afternoon, everyone. So I'll basically not give you advanced tips. It's a simplified tip and simplified techniques that you can follow and stick to, so you can have a good laparoscopic partial nephrectomy. So what is the main aim of partial nephrectomy? The main aim of partial nephrectomy is to preserve the renal parenchyma. But the most important aspect in renal parenchyma preservation is that you don't want a positive margin, and you should have minimized complications following laparoscopic partial nephrectomy. So what is the most important thing? I think for a beginning laparoscopic partial nephrectomy, the radiological imaging forms the backbone of what you are planned to do. It not only determines what are the types of vessels that you are going to clip, it determines what type of renography you might need. It helps you understand where the tumor is, what extent of dissection that you need. So looking at the contrast CT, getting an angiogram done, identifying the arteries, veins, and the supplying vessel is of utmost importance. That will lead to a successful outcome in partial nephrectomy. And one of the things is ureteric relationship to the tumor is very important, because if you don't know that anatomy, you might accidentally cut it, especially in lower pole tumors. Next thing, you want to know whether the partial nephrectomy is feasible in your hand. And there are various scores. I don't think anybody is using these scores to really plan on surgery, but this is important if you want to report. So whenever you do a paper presentation, I think this forms an important part of your of a report, technical report. But for surgical aspect, this may not be of very much importance. What is more important would probably be this Mayo disease probability score, where you can identify whether the fat surrounding the tumors has a toxic fat or not. And it plays a very important role in your journey to a successful partial nephrectomy. If you have a high partial MAP score, then it's going to be difficult, it's going to be bloody, and you may need to convert if you are not an expert in laparoscopy. Position is universal, it's already been talked. So port placement with a simple nephrectomy versus partial is slightly different in that I usually prefer, and most I think would prefer, do a additional port on the lateral aspect for the purpose of suction and irrigation, which is very important when you incise the parenchyma because of the bleed. And not only that, this person should be an equally efficient surgeon. You can't put a nursing staff to perform this because this is your left hand. Until and unless he helps you with partial nephrectomy, it's going to be really difficult to perform the procedure with only your help. Most of all, important point in partial nephrectomy is, or in any laparoscopic surgeries, don't hesitate to put additional ports to improve ergonomics, to improve retraction. So these ports are not going to make long-term difference in terms of cosmesis, but it's going to really help you perform the surgery. So what are the intraoperative steps? Bowel mobilization is standard. Highlight dissection. Some expert surgeons would only dissect the artery and then use it to clamp it. But I advise get both of them dissected and put in a loop. Identify the ureter tract if you are doing a lower polar case. Next step is important aspects is the exposure of the kidneys. You need to make the perinephric fat around the surrounding the border of the tumor free of any fat. So, and it's important that you make the whole surround surface of the tumors around free, and you are able to visualize it by mobilizing. Perinephric fat on the cap or the top of the tumor can be used for manipulation, but I find that most of this is so flimsy and they tend to come off easily. So don't depend on it only for mobilization. And if it comes up, send it for histopathology for detecting local invasion. And regarding mobilization, for upper polar tumors, you need to flip the kidney completely down, especially if you are doing a left upper polar partial nephrectomy. In case of right upper polar partial nephrectomy, the orientation is a bit helpful and you may not need to flip it. In contrast, on the left side, lower polars may not require as much mobilization on the left as compared to the right. Right, you may need to flip the right kidney towards you so you can do adequate suturing. Intra ultrasound and ICC. Basically, I don't think anybody in Nepal have an intraoperative ultrasound, but it's very helpful in identifying tumor margin. And that's why, for me, if the tumor is endophytic, I tend to go for open partial rather than lap because I don't know where the tumor is. And the most important thing is preserving the parenchyma, and open surgeries still has an excellent outcome in doing partials. And ICG is very helpful in determining if you have vascular clamping. Selective vascular clamping has given you adequate ischemia, number one. The selective tumor identification can be done because the tumor is not take up ICG as much as the normal renal parenchyma, and in the end you can determine whether your remaining kidney is well perfused following that. Pedicle control, I usually use Bulldog, but people have been using Sachinsky where they do en bloc clamping. Artery versus artery plus vein. Most people, when it's starting, they usually go for artery and vein. Otherwise, only artery clamping is sufficient. I do a venous clamping when the tumor has a deep extension into the parenchyma and then one of the major veins open up during excision. Then sometimes it becomes bloody and then you might need to clamp that vein so in order to get a negative margin deep in the resection. The advantage of only doing an artery is theoretically there's some perfusion maintained and the ischemia may be slightly offset ischemia may be there. and you can identify the bleeding veins and then suture it adequately. So what is the excision static? Wedge resection was done when it was an open surgery. Now, most of them are either enuclear resection or enucleation in most of the cases in small tumors. However, when the tumor is large, polar nephrectomy, heavy nephrectomies also may be required in some cases. So you have to, depending upon your CT findings, you may need to plan what you need to do. Most important is preparation. Knowing your anatomy is important. Getting your sutures ready. You just can't cut it, then ask the sister for sutures. You need to put in the table the type of sutures that you are going to use, hemlocks, bolsters that you need to prepare, and always put an extra suture because you never know when you're going to need extra. Because with the warm ischemia time, as time increases, then your stressing level increases. Bulldogs with cramp is very important because if it falls down, then it will be easier to pick it up. Inform anesthesia that now you are starting warm ischemia time, that they may help you to keep track of the time if it is required. Rhinography is second most important in terms of oncological control, but most important in your respect and for the patient, because this will determine the post-op outcome in these patients immediately. Because if you don't have a good closure, then bleeding, aneurysms, urine leak, that creates morbidity. So PCS closure, you can do it either separately with suture or included in rhinography. I've done both. They have no difference in outcome. You can choose whatever you like. Separate closure sounds sexy, but outcome is same. For inner rhinography, I usually use barbed, 2-0 barbed sutures, but sometimes it's not available. 2-0 Vicryl is also sufficient. Outer rhinography is always barbed. Inner rhinography only is required if it's more of a hilar tumor and is a large defect. And yesterday they have shown that they put various gels and hemostatic agent and complete with only inner rhinography. Can we reduce the ischemia time? Yes, unclamping early after following rhinography can help. Selective clamping, that's clamping only the supplying vessel can help. And delayed clamping. Delayed clamping is you cut the cortex and go up to the level where bleeding is sufficient, manageable. Once starts to bleed, then you can clamp the artery, then continue with the resection. So that can help. Various adjuncts, use of perinephric fat to cover the defect also helps in reducing the urine leak. Surgery cells, closure of zero, these are the standard steps. If there's bleed, you can increase the pneumoperitoneum. Sometimes if the clamps are old, then single clamp may not be sufficient. You may be required to put second bulldog clamp. Try venous clamping if it's not sufficient. And always go back to the city. You might have missed a branch when you are clamping. And do not hesitate to reclamp if your clamp is not sufficient. So this is a case of a 32 years male, referral mass. And so the steps are used, just vascular isolation with artery and vein. This is a lumbar vessel. So in order to isolate the renal artery, then go over, make the peritumoral area bare. Get it mobilized so it's oriented. Clamp, then start cutting out the margin. Don't panic, go slow. As you go, the suction and irrigation is very important. As you cut, you will once reach a capsular area, and then that is the area where you will form the mark where you can start cutting. Continue with cutting, and as you see, the irrigation and the suction guy is very important for you. Without him, it will be very difficult to excise. Go slow and be meticulous. After excising, the most important in terms of post-op morbidity is the rhinography. He is thought inner PCS is open, so it's separately close the PCS if you want. and do a two-layered rhinographic closure. So because in terms of time, this is a standard technique of rhinography. You do the inner rhinography and then continue with the outer rhinography. And in this case, after completion of the inner completion of the, you have declamp to reduce the ischemia time, and it doesn't create a big issue even if you declamp for outer rhinography. It may bleed a little, but you can continue. You can see the well-perfused kidney. So I'm just fast forwarding. And use of Surgicel or even a fat to just bolster the area will help you sleep well. So in the key takeaways is preparation is the key, planning is the key, know your limited partial nephrectomy. As I iterated before, open partial nephrectomy will give you equally good result if you functional result on the long run, except for the scars. Oncologically, it has also good, and depending upon expertise, don't be egoistic and plan for lap if you can't do it. Thank you.
Thank you for the nice video. Due to no time constraints, no questions are allowed. May I now request the next speaker, Dr. Jubin Silwal, to present. Okay. Okay. Role of robotic assisted laparoscopic partial nephrectomy in the management of complex tumors. So after seeing the lab, you come for the robot and then choose which one you want to do, lab versus robot.
Good afternoon, everyone. Yeah, I know there's a shortage of time right now, pre-lunch session. So, in fact, my job has been made a lot easier because throughout these 2 days, we have been discussing a lot about the role of robotics versus laparoscopy. And my topic is partial nephrectomy, robotic partial nephrectomy for complex renal tumors. As my previous speaker has already pointed out, the technical details for a partial nephrectomy laparoscopically. So my job is more to, compare and the outcome of robotic versus a laparoscopic and try to establish why a robotic partial nephrectomy would be better for complex renal tumors. I have no conflict of interest, although I am not an expert in robotic surgery, but I had the opportunity of doing a fellowship at NUHS Singapore recently, so where I was able to come across a lot of partial nephrectomies. I won't go into these details of the indications and complexities, but preferably by going by the guidelines, all the T1A tumors, even T1 tumors are indications for partial nephrectomies, but the absolute indications would be for solitary kidneys, for bilateral masses, and patients with CKD. The renal score, the Padua score, as my previous speaker has already mentioned, that it does not have that much of a surgical indication. I won't go into the guidelines of the renal mass. The targeted outcome in partial nephrectomy, the trifecta and the pentafecta effects, already been mentioned, but the pentafecta effects not yet established because we do not have many studies or long-term studies comparing the outcome on a long term. So the pentafecta effect has not yet been established, but the trifecta, going by the trifecta effect, robotic partial nephrectomy definitely has a better outcome than a laparoscopic one. While doing complex masses, be it the hilar masses, the multiple masses, the endophytic masses, the challenges would be a longer duration of the surgery, longer warm ischemia time. Due to the close proximity to the renal vasculature and the collecting system, more chances of injuries. The toxic fat, as mentioned before. Tumor localization, yes, as we do not have an intra-op ultrasound yet now in Nepal, but for a robotic partial, yes, a tumor localization ultrasound would be very essential. The resection techniques and the rhinography techniques have already been described.
Going by few studies, one of the larger studies, the Rostula robotic surgery for larger mass, in one of the studies where they compared the tumor in a patient, we did a study in 298 patients with renal score of 9. The average one ischemia time was 25 minutes, estimated blood loss to be around 150 mils, intraoperative complications in 5.4%, and postoperative 5%, CD more than 3, and positive surgical margins in 8%. This is just the same study in a tabulated form. In another study done in a single center retrospective study, the trifecta achievement was 88%, and intraoperative blood loss was lower with the retroperitoneal approach. Warm ischemia time, there was no significant difference, and positive surgical margins, they did not mention about that. The mean follow-up was only 11.3, so the pentafecta effect could not be established in this one. Just comparing few cohorts, just the gist of it, the ischemia time, warm ischemia time was under 25 minutes in the larger series, whereas the further one in one of the study, it was 31 minutes. But going by that, the complication rates was only around 5.4% and 5.1% in both the studies. The oncological outcomes, we are more concerned about the positive margins. So yeah, they mentioned about 8% in one study and only 1.9% in another study. Okay. So yeah, I'm not trying to, root for the robotic partial nephrectomy, but in one of the study, the median ischemia time in a laparoscopy versus radical was quite comparable, 27 versus 23 minutes. And the trifecta achievement was reportedly quite high in RAPM. And eGFR decline was also quite low in cases of RAPM. This is just the same thing in a graphical presentation. And this is the serum creatinine and GFR comparison in another study, which showed that relatively lesser decrease in eGFR in case of robotic partial. The consideration for a better outcome would be early versus standard unclamping and intraoperative ultrasound and the use of ICG. I'll just like to skip this. And this is this is showing an early unclamping with rhinorrhaphy only for the inner layer, and then unclamping resulting in a lesser warm ischemia time. These are the resection techniques used, and enucleation versus standard resection does not have that much of significant outcome in cases of blood loss and operating time. So yeah, depends upon what technique you are comfortable with. Pre-op 3D image reconstruction has made it very easier just to outline, first is to outline the tumor as well as to know about the vascular supply. There's this one case with a nephromatous score of 10. This is a completely endophytic hilar mass, as you can see in the CT scan here. And a 3D reconstruction of the same. This is the, okay, sorry. Yeah, so this is the 3D reconstruction of the same tumor where we can see the multiple, the vascular supply of the tumor. So resulting in, this is a software, the Synapse software developed at NUHS by Professor Tiong Hoi and his team, where we can interact virtually with the 3D model of the tumor and then plan the surgery accordingly for selective clamping of the vessels. This is the surgery for the same, and where we see that the artery has been already, the main renal artery already clamped, and the feeding vessels that has been already been ligated, and then the resection is. The main advantage of this software is that we can interpose the same software with the 3D image on real time during the resection, resulting in anticipation of the vasculature as well as, it makes easier for the clipping of the vasculature. So as we can see, the real-time image interposing with the the mass, the resection there, real-time resection there. So yeah, after the resection of the tumor, yes, this is the complete resection of the tumor, and then, yeah, the PCS closure is been doing with a barbed suture. And then early unclamping was done, right, resulting in a shortened worm ischemia time. This is the picture 2 years after the surgery, showing the tumor was a PT3A ISUP grade 3 clear cell RCC. And 2 years down the line, the scan shows that the margins are clear. Next one, a large cystic mass involving the lower mid-pole, and it was the ultrasound and the MRI scan was suggestive of hemorrhage into the cyst. So the technique here that I'm trying to demonstrate is that because of the large cystic mass, the complete mobilization of the kidney may result in spillage of the tumor from the cystic mass. So the idea is to straight away go and clamp the renal artery without mobilizing the lower pole of the kidney. So we are trying to establish a plane in between the aorta and the IVC, and then yeah. So yeah, I'll just wait, and yeah. So this is the renal artery where we have localized it without mobilization of the lower pole of the kidney, and then selective, and then the clamping of the renal artery was done, resection of the mass done. Okay. This was the resected mass with, and the histology showed a clear cell RCC, PT2B, 11 centimeter mass, and the margins were negative. This is the post-operative image 4 years after the surgery, where we can appreciate a clear margin. So in conclusion, the decision for partial nephrectomy should be based both upon indication as well as the expertise of the operating team. We should know our limits, even though the boundary seems to be expanding. Robotic partial nephrectomy has a superior role for complex masses, basically with the decreased worm ischemia time and the lesser incidence of a positive surgical margins as evidenced by various studies. I'd like to thank you all for the patient listening.
Okay, thank you, Dr. Zubin, for sharing and your nice videos, particularly those complex cases where I think robotics, I'm a little bit biased having transitioned to robotics. I feel that it does give a lot of advantages. Of course, you know, there are very skilled laparoscopic surgeons who can kind of execute some of those cases too. I also found the use of the three-dimensional preoperative planning simulation model very useful. The fact that you can kind of interplay with it preoperatively and also intraoperatively. I think that's the direction of travel in terms of innovation, and you know, that's something that again robotics will be very kind of at the forefront of, although that's not in routine clinical practice at the moment. So thank you very much.
Thank you.
I think any concluding questions? No. No.
With this, I think, thank you, Dr. Jovin. With this, we will close the session. With a slight change in program, we'll go for lunch now, and the panel discussion will be after lunch. Thank you.
I would like to request the panelists, Dr. Parasmani Shrestha, Dr. Uttam Mete. I think I will have to wait for Sobnis sir. Dr. Umesh Nepal, Dr. Robin Joshi, Dr. Rajesh Bhataju, and the moderator for the session is Dr. Nirmal Lamisane. I would like to request all the faculties to conduct this session. Thank you.
म त यहाँ छु नि Good afternoon. Dr. Anil asked me to make a discussion on management of renal mass in solitary kidney. The idea was to balance the oncological control as well as to preserve the renal function as much as possible so that the patient will not be rendered anephric or he fall into CKD and the subsequent treatment is necessary for lifetime. The idea here is a renal mass is there in a solitary kidney. To discuss this issue, we have invited faculties, Dr. Umesh Mehte. I don't need to introduce her here. Dr. Savni sir will be joining soon, I am sure. Dr. Shashikanta Mishra, I heard, has left for Zomsong. We wish him a good journey. From the Nepal side, we have myself, Nirmal Lamichhane. I'm moderating the session. And joining with us is Dr. Parasmani Shrestha, Professor of NAMS. Dr. Umesh Nepal, Consultant Urologist from BP Koirala Cancer Hospital. Robin Joshi, Professor of Urology from KISS Medical College and Nepal Cancer Hospital. Rajesh Bataju from Consultant Uro-Oncologist from BNB Hospital. Just briefly, a bit of incidence of solitary functioning kidney. Essentially, there can be two types. I mean, congenital solitary functioning and acquired, which consists of about 65% and 30%. If you see estimates, global prevalence of solitary functioning kidney is 1 in 1,000. I mean, it's quite a number, but I don't know how we don't see much of those. Unilateral renal agenesis in 1 in 2,000 live births, renal aplasia in 1,300 live births, multicystic dysplastic kidney in 1 in 4,500. Autopsy prevalence is 1 in 1,000. And familial occurrence about 10%. And CKD risk, all SFK is about hazard ratio of about 3.2. In US data says, US nephrectomies, cancer registry data says 8 to 17, there is 2,55,000, and it's because of nephrectomy for cancer, and for living kidney donors, it's about 60,000. So we knew that SFK is about 1 in 1,000. If you take it in worldwide global data, the patient is at higher risk. Who is at higher risk? Essentially is a cancer patient, renal cancer patient. While we cannot give a precise population-based percentage of how many SFK patients develop renal mass, Cleveland Clinic's data of 1,024 patients says they found about 47 years of experience. They regularly encountered those cases because being probably becoming a high volume center. When SFK patients do develop a mass, nephron sparing approaches are feasible in about 90% of cases because most of them are nephrectomized patients and they keep on coming in follow-up. So you should be able to pick them early, and dialysis is available in about 90+% of cases. The objective today would be how do we make a diagnostic workup whenever a SFK patient comes to you, pre-operative precautions, nephrometry scores. We are trying to discuss very basic things to make sure we just review things on and on so that we don't forget whenever we need those things. And treatment methods we have in hand, depending upon your scenario and post-op treatment and care, prognosis and survival as well. Indeed, this case was operated by us 2 years ago. A 60-year-old male from Chitwan district itself. The history of right radical nephrectomy 8 years ago for clear cell carcinoma T2 disease. Now presents with incidentally detected left renal mass with ultrasound. Comorbidity-wise, he had well-controlled hypertension. In imaging, which I could retrieve from his case records, was solitary left kidney, 4.5 centimeter solid endophytic type of mass centrally located, averting the collecting system. Renal nephrometry score-wise, R was 2, E was 3, N was 3, and L was 2. It's essentially a 10, so it's considered as a high complexity mass. CT was performed, chest, abdomen, pelvis. There were no obvious metastatic nodules we were able to see. The core challenge here is the mandate is to achieve complete oncological control, negative margins. The imperative would be to preserve maximum renal function to avoid dialysis in the future because he had solitary kidney, which also had tumor. The consequence of failure from our side would be end-stage renal disease, which carries a bit of mortality risk as well. And he will be kept for dialysis in future time. In our Nepali context, essentially, even the dialysis facilities are also not widely available in a different part of the country, so we need to be more cautious to treat these patients. The balancing act would be every minute of ischemia and every cubic centimeter of resected parenchyma really does matter for this patient. At this point of time, I have a question to the Dr. Parasmani Srestha, as it was designed. What would be the CT requirement in this particular patient you would be asking? Basic things and the lab requirements.
Can you?
The patient is 60-year-old male with a 4.5 centimeter nephrometry score-wise 10 tumor, who has got a solitary kidney. And let's say this patient comes to you and you need to ask a CT scan for a particular patient. What are the things you should be asking? Because sometimes even the CT scans are not properly done. We want to know what phases would you need, how the CT should be performed.
These kind of cases, normally what we do is we normally talk to the radiologist on personal basis. So we always, of course, creatinine level, and sometimes creatinine level is a bit high, then we sit down and talk. Maybe we can hydrate the patient and do something. And the other thing is, if you can get CT angio at the same setting, so it will be quite helpful because as we seen in the previous lectures that you can really design, and even nowadays, if some hospital have got this provision, you get the 3D imaging and you can do a better job.
The idea here would be to discuss with the wider audience. There has to be a baseline non-contrast CT, as well as there has to be a good arterial phase. The nephrographic phase has to be there and delayed phase, as well as angiographic films or 3D reconstruction whenever possible. Ounce-fill value-wise, Dr. Paras, do anything to add?
I think, yeah, this is it. Whatever you have shown would be good enough, I think.
If a lesion is less than 20 on non-contrast, it should be something simple cyst. If it enhances more than 20, it's a solid tumor. The danger zone would be from 20 to 70. On non-contrast, where hemorrhage or proteinous fluid can mimic solid tissue. So at this point of time, you have to have a good nephrogenic phase of a CT so that you can see if this lesion is getting up more contrast. If you see the CT can predict tumor type sometimes. If more than 100, this is not very, very accurate, but nonetheless you can guess a little bit. The clear cell tumors would be very enhancing. Papillary is probably less a little bit. Chromophobe is variable. Angiolipoma and etc. Are negative HU values. Of course, we need to do a good laboratory assessment as well to make sure the baseline renal metabolic workup as well as renal function tests. Here, I would like to ask Dr. Rajesh Bhattaju to talk a little bit more on nephrometry, things that comes in our mind when we deal these type of cases.
great complexity of the tumor, renal tumor. More than 10 is complex renal tumor. High risk, high complexity.
Does your radiologist give you this information whenever CT reports comes, or you need to measure it yourself?
No, we normally in this sort of scenario, we discuss with the radiologist regarding the complexity of the tumor.
The idea here is we need to discuss, we need to have a, Mehta sir wants to say something?
No, I just want to tell, because some residents are also sitting here.
Yes.
Previously, you had talked about the CT scan. And many a times, some people, they don't go for a non-contrast CT, which is very wrong, which you have pointed out. Suppose somebody has not done non-contrast CT, what is the way out? That is the question I usually ask during exam also. That is, you go for a washout phase. That will give us an idea. So that is the answer.
Thank you, sir, for highlighting the important issue. If there is directly contrast CT has been performed, then there has to have one washout film so that there will be no contrast in the kidney, so that you can see a plain CT scan to see the ounce-filled values of a particular tumor as a baseline test. There are other nephrometry scores used. I mean, depending upon your local practice, you can always ask for a Padua score or some other indices, but the renal nephrometry score is...
And one more information is,
please.
On CT scan also, the tumor as per the density, you divide them isodense, hypodense, and hyperdense. For isodense lesion, it's very difficult to see the tumor, especially if it is T1A. And how to look for it, in which phase, that is the reason of why you need a nephrographic phase. That is the best phase where isodense lesion can be picked up.
May I highlight? The limitations of nephrometry essentially is it's an anatomical thing that you get. There will be no histology. From the CT scan itself, you may guess the type of the tumor, but it's anatomical information you will be gathering. There will be no molecular data or patient factors. There would be inter-observer variability as well because of the variation in measurements and etc. And it obviously doesn't account for any renal function or comorbidity issues. Dr. Joshi, what is your approach to renal biopsy in these type of cases? When do you think these are indicated?
In this type of case, solitary kidney, I think wherever possible, you have to go for a partial thing. But if you can talk with your radiologist and do any form of biopsy like FNAC, you have a tissue diagnosis. You can always go for a new adjuvant TKI, downgrade it, and go for a simpler type of partial nephrectomy. Then wherever possible, I think tissue diagnosis should be there if you really want to preserve the kidney in this case.
Mehta sir, want to add something?
So this is just for the residents. Yes. So in terms of renal biopsy, say you have two pathways. One is diagnostic pathway. You have two situations: diagnostic pathway and therapeutic decision making. For a diagnostic pathway, you have on the one extreme very small renal mass. On the other hand, you have a borderline, and third is metastatic disease. If it is a very small, like less than, say, T1A is the small renal mass, that is also subcategorized to less than 2 centimeter, more than 2 centimeter. Because if it is less than 2 centimeter, probability of having a benign disease to the tune of 20% and mixed variety is 40%. So that means if you keep on giving therapy to these sort of patients, you will be over-treating. So those cases, very small, then you have, if you really want to be sure, that is one. Number two is when you have a diagnostic difficulty, you are not sure whether you are dealing with a malignancy or an infective pathology or a lymphoma, or the malignancy is there, but the treatment is not the surgical. It is a medical treatment. So these are the three situations where you should go for biopsy. And third, and the fourth one, the extreme, other extreme, the metastatic disease. That's what he was trying to say, that you want to know what sort of therapy will be required. Say, for example, if it's a clear cell carcinoma, therapy is different. If it is papillary, therapy is different. So for therapeutic purpose, you can go for this. That is the answer we expect during exam. Okay, I think Dr. Savnis said was.
Dr. Savnis, sir, want to add something?
So biopsy, only if there is a diagnostic dilemma, especially in a solitary kidney or borderline raised creatinine, because you want to be very, very sure. And as is rightly pointed out, that if it is a small tumor, then there is a dilemma. Otherwise, there is not much dilemma.
Not much needed. Yeah, I mean, in solitary functioning kidneys,
Ablative therapy, that all you know. So what sort of therapy you want to give? If you are going for a surgery, you are going to have the tissue, you are going to have the pathology. But if you are going for a therapy like cryotherapy or ablative therapy, then it is mandatory to have this biopsy.
If there is a solitary kidney, or many times we have a situation where the other side kidney is there, but both are not properly functioning. Maybe creatinine is 2.5, 3, and you have a detected solitary mass in one kidney. That is where the diagnostic dilemma comes in. You can't really do the CT angiography, the contrast load is too much and this that. So in those situations, you can always do MRI, wherein they will give the appropriate diagnosis, and they also will give a little bit of vascularity pattern and other things. So even in a high creatinine, that is quite useful.
The EUA suggestion wise, it's if it is less than 4 centimeter tumor, there is a 20 to 30% chance of having a benign tumors. It can avoid over treatment. Before thermal ablation or any type of minimally invasive, you probably need to have one biopsy to make sure this is a benign disease you are. And the solitary functioning kidney sometimes is nicely mentioned by two of the professors. If you have question, you should be able to make sure you are not dealing with a benign thing and doing a surgery unnecessarily. Biopsy technique wise, it is usually done coaxially nowadays. So multiple cores are taken, 2 to 4 cores from different areas, so that there will be less chance of tumor pathway seedling of the tumor. And nowadays this is done under CT or ultrasound guidance, so that the tumor is pretty much focused. MRI guidance is also possible in specialized centers. On-site pathology assessment is necessary, if available, would be good. And the diagnostic yield and safety wise, the biopsy has got very good safety profile, less than 1% requiring transfusion, and a high bleeding risk procedure due to retroperitoneal area, but SIR classification wise this is less, and tract seedling, it is now not much considered as a issue. Anything to add from the professor, sir?
In a cystic, suppose if it is basically a cystic mass, even if it is a solitary kidney, and you have done contrast enhance, and there is a cystic mass, there is a dilemma. Now there is a periphery is enhancing, or septae are enhancing, or there is a wall which is a little bit enhancing. Those are not situations for biopsy. You can't do biopsy in that. So in those cases, you have to avoid biopsy and then go ahead with the surgery.
So, sir was talking about solitary kidney with a cystic mass. And now, as you all know, that you just classify as per the Bosniak classification. So, and few percentage of cases, you see, even if it is a Bosniak 3, 50-50 chances. So you are not sure. So radiology is also not sure. In that case, we go for contrast enhanced ultrasound, which is supposed to be 100% specific, that whether there is no cancer. So that way, that step is good. And second thing is about the biopsy versus FNAC. For renal mass, usually we go for a biopsy. Why? The answer in the question will be what you want to know. You want to know the type of pathology and the grade of the tumor, because grade of the tumor also will influence your treatment. In an FNAC, where the 23 gauge needle is required, that will not give us a tissue, just cells. So that will not give us a grade. So that's why if the question, whatever is given in the exam, you have to have a needle about 16 gauge needle, so that you can have both type as well as grade.
Okay. But we need to have a histological biopsy. It is said that in cystic masses, definitely, if you really need, you can do, but the yield is less, which is probably 40% or less. This patient didn't have any biopsy, and he had a CT scan which showed renal nephrometry score of 10 with a solitary functioning kidney. My question to Dr. Umesh Nepal would be, what is your preferred approach in this scenario to move further?
Thank you. The most important thing in this patient is, because the patient is a solitary kidney we need to preserve as much renal parenchyma as possible. So the did you ask about the surgical? I mean, can I see the question once again? Okay, preferred approach. That would be a partial nephrectomy.
What else? I mean, are there in a spectrum of treatment?
Partial nephrectomy, and considering the complexity of the tumor, I need to preserve as much parenchyma as possible. I need to understand if I have the luxury of intraoperative ultrasound there or not, because this is seems to be an endophytic tumor. So cold ischemia, open partial, retroperitoneal approach maybe. May seem, but one expert in laparoscopic surgery can do fast suturing and without maximizing the time, ischemia time can also do, but that seems to be logical.
Sabni sir would highlight some, sir.
Partial nephrectomy is the treatment of choice, there is no doubt about it. Now, how do you do partial nephrectomy, whether it is robotic or whether it is open? Now, as the complexity increases, the tumor is endophytic, then obviously there are certain requirements even if you do robotic surgery. Now, robotic people, expert people, they are doing a lot. Yeah. Even the central location and is that once you have proper mapping and all, can be done without any problem. But one has to understand that intraoperative drop-down probe with ultrasound is absolutely mandatory. Otherwise, you will be confused and you will end up in losing a lot of renal mass along with the tumor. So that is definitely necessary. In case if you think that a robotic is going to be a little difficult, the mass is not properly seen and is that, then there should not be any hesitation in doing proper partial nephrectomy, open approach, wherein you can control the renal artery, renal vein, give hypothermia. The biggest difference of open versus partial is that you have a lot of time available with you in open surgery because you can do hypothermia. Whereas in robotic surgery, the biggest difference is that you are always under constant pressure of finishing on time. Because on one hand, even if you do a proper oncological surgery, and if you exceed the time, then eventually in a solitary kidney, that itself will compromise the nephron function of the preserved kidney. And therefore, this decision you have to take yourself, how much experience you have in, how much confidence you have in doing robotic surgery, or straight away go ahead with partial nephrectomy in open surgery. But laparoscopy, I don't think in a case like this may be feasible because whatever you do, the one cannot be so fast in laparoscopy even if he is really expert. So robotic or the open, that is what is the approach.
Thank you, sir. Considering this case, I mean, there are a lot of options. I mean, depending upon the case-to-case based scenario, you have to decide. But in this particular case, he looks to be medically fit with a 4.5 centimeter tumor. Staying in a Nepal where robots are not widely available or even not available, nicely mentioned open surgery with enough time, cold ischemia would be a nice bailout option.
I think, sir, we had a presentation by Abhishek from your center, and he nicely shown 3D image and all the vessels, and he was doing central tumors. I fully agree. If you can do a robotic in a good high volume center, I think that is the way. That is the way out.
So there are plenty of centers who are doing in a complex cases.
In a central one, central.
So that approach is individual variation, but there should not be any hesitation of doing partial nephrectomy just because robotic.
And in our context, as you rightly pointed out, cold ischemia and warm ischemia. If you do an open surgery, you have enough time, cold ischemia time. You can relax. You can denilate everything and do a good partial nephrectomy. Right, sir?
Can I just say? So because I'm doing more than around 15 years of robotic surgery. So definitely if the patient's other kidney would have been normal, I don't have any problem going with the robotic partial nephrectomy. But here is a situation, patient has got a solitary kidney. I will not shy away to go ahead with an even open partial nephrectomy. It is an endophytic tumor, high complexity tumor.
For the sake of academic discussion, Vascular control wise, by resection technique and other special techniques, you can see it can be on clamp, off clamp, selective clamping, zero ischemia, cold ischemia. By resection technique wise, there could be a wide resection, nucleation, nuclear resection, heminephrectomy, segmental resection. There are different names. Definitely there are some differences in how you do it. At the meantime, there are some special techniques like ex vivo partial nephrectomy, laparoscopy assisted ex vivo partial nephrectomy, and some other hybrid techniques and robot assisted partial nephrectomies. I mean, these are for the sake of academic discussion. Now I am here with some question to Dr. Professor Mete. How should we choose method as per renal score in this particular patient, sir?
So definitely what we are going to do a partial nephrectomy. Now the two questions which Dr. Sabnis was asking, that whether I should go for a laparoscopic robotic or this thing. So what should be the approach and what should be, see the three key steps during partial nephrectomy is the vascular control, resection and renography. All three steps are going to define your goals. The goal is to have a normal parenchyma or less reduction of EGFR and oncologically safety. Now, this nephrometry score gives you an idea. If it is more than 10 or plus, this is a high nephrometry score, it is going to tell me that it is going to be a complex surgery, and because it's a solitary kidney, maybe you should go for an open approach. That answer it can give, number one. Number two question is whether you want to go for a complete ischemia, I mean global ischemia or a selective ischemia or something like that, that will be given by this, because you know it's a complex tumor, it will take more time, but you don't want to waste that time. That means most probably you will require a cold ischemia. So, and that cold ischemia, Sabnis was telling, it is possible. Of course, we had seen in the early phases of laparoscopy, people used to do cold ischemia during laparoscopy also, lot of difficulty. But if it is a cold ischemia, it has to be an open partial nephrectomy. So that is going to tell me what should be my vascular control. Third questions which it is going to ask me whether it will be an enucleation or a resection, because we know it's a solitary kidney and complex tumor, you may require for the oncological safety, but it is well encapsulated. If it is an well encapsulated tumor, most probably enucleation will be better. And the history of nephrectomy 10 years ago, and the histology is CC, RCC, that also gives me some information. That means most likely this kidney is going to have CC only clear cell carcinoma rather than other papillary tumor. We know the papillary tumor are multicentric. So having a possibility or likelihood of missing other tumor is also less. So that means that will give me an idea. So that is most probably enucleation will be good enough. And third thing is the renography. And you are telling me 10 and it is endophytic tumor. As you all know, when you go for a renography, if you are going to go for a renography for the medulla itself, then you are going to go the interlobar artery. If you go and suture this interlobar artery, even if you have left some parenchyma, that will be devascularized. Yeah. So how to devascularize, to prevent the devascularization, it will depend on what sort of renography, single layer versus double layer, what you are going for the medulla. If you are going to medulla, you should be very careful that you should not take an interlobar artery, because when you are go for a single layer, only cortical renography, that means you are going to go for in arcuate arteries, which will not give rise to that much of ischemic tissue. So all three goals, what are you going to do, this nephrometry score can give me the answers.
Thank you, sir.
This sort of high complexity tumor, will you routinely put urinary catheter?
Now, initially when I had started my partial nephrectomy for open surgery, started with the open and then lapan, So there, you know that may be opening of the PCS. So what I should do, rather than putting an ureteric catheter, it takes another procedure. What I should do, I have to dissect the pelvis, renal pelvis, make a small hole, put a feeding tube, and put saline, and then you can just close that thing. So that will avoid. But nowadays, what I have seen, by putting, there's no need for ureteric catheter. You can just suture it, and it helps. It usually, a nephrocutaneous fistula or leakage, it doesn't persist, unless it is a lower polar tumor. That's why nephrometry score, polar region, why? What is the importance of polar locations? If it is a lower polar tumor, chances of renal leakage is very high. In the upper pole, even if it leaks, it is going to heal. So that also gives some idea.
Okay. Here, my question to Rajesh would be, we didn't use any ultrasound in this case. Can you elaborate the use of ultrasound? I mean, in this
regarding
type of
the
cases?
intra use of ultrasound, this is a real-time image, and especially very important in total endophytic tumor, high complexity tumor. It will help to identify the tumor, depth perception, and the margin demarcation that will preserve the parenchyma, especially in solitary. And also, it can use to map vascular mapping.
If you are
It
able
can
to see.
sometimes find the feeding vessels. And yesterday we had a very good talk from Dr. Abhishek Singh. He had demonstrated the ultrasound, which detected the baby tumor, which was not visible in the CT scan itself.
Ultrasound issue is you need to learn it, and then if you can learn it properly, it guides you from different aspects like tumor localization, margin delineation, vascular mapping, collecting system mapping, as well as resection guidance. If you are able to see properly, I mean, you need to learn. Majority of us probably don't know how to use ultrasound, but if you learn it, I guess it is useful.
This should be a part and parcel, especially for endophytic tumor. Because what we are telling is correct. First, you have to localize. On the surface, nothing is projecting. So you have to localize. And then how to reach the tumor. Either you can remove a chunk of tumor or you go for a nephrotomy and reach there. So that will be also helped by the ultrasound. Because of the time constants you have to run.
Yeah. I will keep the Shashikant sir's questions. But still here, I would like to hear from Professor Sabnis. Have you have any experience with those ex vivo techniques, etc., just for the sake of fantasy, sir?
Whatever complexity tumor, you don't really have to remove the kidney, do everything on the bench and then put it again. That is not required. We have not done that for many, many years now. So even in vivo, once you are doing open partial nephrectomy, that is more than enough to do everything in situ. So you don't need that. Now, the question is, the previous question was that whether it is margin, resection margin, or it is enucleation. Nowadays it's very clear that you don't need to preserve remove the 2 centimeter margin and things like that. Even one single margin is enough. So every partial nephrectomy is as good as enucleation nowadays.
And what is enucleoresection, by the way, sir?
Yeah, what you are asking?
Enucleoresection, I mean, sometimes it's difficult for all to understand.
No, see, you see, once you are, say for example, if it is an exophytic tumor, you know everything where exactly the tumor is. Then as you keep on cutting, with this, you see the tumor and you see the parenchyma. There is a clear-cut difference you can see. The clear-cut capsule is there, and then you just, in the vicinity of the capsule, you take out the tumor. Some parenchyma you always come when you open the cut surface. You always see there is a little bit of parenchyma, but you don't have to really go wide margin and this, that. That is not required nowadays.
That's what we are telling. What is enucleoresection? That means the specimen should contain part of the parenchyma in part of the specimen. That means when you are starting, so where you are starting, you don't know. You are starting most probably at the parenchyma level. Then you go, as you progress further, you reach the capsule. That means from starting to reaching the capsule, there's some area where parenchyma will be left behind in the specimen. That is the enucleoresection. So you are doing enucleation in the later part, and the first part is the resection. Okay. But if you start from the very beginning going into the capsule, that is the enucleation.
Okay, mix of both. The brief question to Dr. Sabnis is here. What's the wisdom in clamping, sir? How cold ischemia logistic-wise and ice flush technique?
Cold ischemia, once you open this kidney, you have to take the control of the artery and vein both, and you have to clamp both. Both, artery and vein both. If you clamp only artery, and if you give cold ischemia, then there is always risk of a systemic hypothermia. So you have to clamp artery and vein, and then, so proper this ischemia, cold ischemia is in place. What we do is that we push ice slush for about 8 to 10 minutes, remove the ice slush. So by then the core temperature in the side of the kidney significantly goes down. Now you see remove the ice slush and then keep on injecting cold saline continuously, keep on sucking it. Then whatever you want to do it, you do it. Now, if you don't clamp the vein, what happens is that again the field becomes messy. There is some little bit of oozing which keeps coming. And therefore, if you want to have a quick surgery, if you want to have a proper, precise surgery, artery and vein clamping is without any problem. if you give proper cold ischemia, if you restrict proper timing, it doesn't have any morbidity or renal loss. So that is, zero ischemia is of course without clamping anything. Then it's the most peripheral tumor. You don't have to clamp and they just keep on cutting and then take sutures, that's it. For preoperative measures, patients have to be properly hydrated. Mannitol has to be given before you clamp the artery and vein. And to prevent AKI, you have to have as much quick as possible.
In some point, maybe I'll differ with Savni sir. Why I don't clamp both artery and vein? If I prefer, I do prefer on the right side, left side I don't prefer. Why? Artery you have clamped, so there is no circulation going into the kidney, so venous return will not be there. So the concern that maybe the cold blood is going into the blood, will produce systemic hypothermia, most probably is not correct, sir. Well, I don't know. So that's what I do it. So because there's no circulation, when nothing is drained by the vein. So that is only to this thing. That is one thing. And second thing is regarding mannitols, you are also doing lonely transplantation. So you are still giving mannitol? So we don't usually use the mannitol. Any renoprotective measures, usually you are not taking it because it has been shown in the literature. It's not in my experience. It has been proven in the literature that it hardly makes any difference whether you give this. Because even if you go for a cold ischemia, it usually doesn't exceed more than 50 minutes. So not more than 50 minutes. So that is why it is really...
Probably the last question, sir. What probably is more important? Is it ischemia time or a preservation of renal parenchyma for the sake of long-standing renal function, sir?
Sorry. Both are important, but there is a renewed interest about the timing. People say you should not bother for the time. You do the good job. Take care of this thing. Okay. Oncological care is most important. So time most probably, but time is if you carry on with the 80 minutes, definitely it is gone. So how much time? Time is time. So 25 minutes usually is for warm ischemia, 20-25, maximum 30 minutes.
Yeah, yeah.
But for cold ischemia, not more than 50 minutes. 50.
Yeah. Message here is less than 30 minutes for warm ischemia, and if it is cold, probably 60 minutes. Am I right, sir? Cold ischemia time.
There is no limit as such, but as you increase the cold ischemia, some loss of irreversible parenchymal loss is bound to be there. So it is not that it is now just by clock it is 20 minutes, 30 minutes, 40 minutes, not like that. But you have to finish as much early as possible. Warm ischemia should be as minimum as possible because the renal irreversible nephron loss will be directly proportional to the increase in the warm ischemia time. Cold ischemia time, you have a lot of flexibility. You can really extend it. It's not going to make much difference. Even if there is a difference, it is only in the early period. But the recovery will be there. So,
any learning issues, sir? How many partial nephrectomies should you have been performed before you attempt an solitary kidney, or any words of wisdom in this regard, sir?
Words of wisdom, if you are talking of the robotic partial nephrectomy, you have to start initially with the simple tumors. Don't take solitary kidney, don't take complex tumors, don't take central tumor. Even if the other kidney is normal, central tumor, high renal score, don't take it in the beginning. Once you are confident of doing, understanding the planes, understanding how exactly the enucleation is done, how the suturing is done, where exactly is the sutures to be taken up. Once you are well versed with the simple cases, then you go for the central or little complex tumors. And solitary kidney, you have to assess your own confidence level. You should be confident. You should not be overconfident of doing things.
Exactly what I would like to say that rather you should know when not to do the robotic surgery. This is the situation where solitary functioning kidney 4.5% where centrally located tumor, patient wants to survive without any renal replacement therapy. In that case, you should not shy away to go ahead with the cold ischemia.
Thank you for highlighting. This patient was operated open with a cold ischemia, and he is 2 years down the line. May I ask Dr. Umesh Nepal here, what would be the long-term follow-up in these type of patients, sir?
Thank you. For the follow-up, most important thing will be general examination and to look for the blood pressure, if there's, and then the urine analysis. And then the imaging. Imaging should be as shown there. every 6 monthly for three years is to be done. Also, we have to, in every visit, we need to, if possible, calculate the EGFR of these patients also.
The EUA guideline says functional follow-up of renal function in each visit, cardiovascular risk prevention and monitoring, oncological follow-up with CT scan 6 monthly, and then annually for consecutive 3 years. And then, as indicated, the considering curtailing of risk of dying from other causes versus recurrence. It's okay. With this, I thank my panelists for being here to having such a lively discussion of this very, very specific topic. Thank you all. Have a nice day. Sorry for taking a bit long. An eminent professor discussing with us.
Thank you, sir. I would like to request everyone to stand by for the photographs. Thank you.
I welcome you to the urolithiasis session. I'd like to call upon stage Professor C.S. Agrawal sir, Professor Dhruva Bahadur Adhikari sir, Dr. Dipesh Shrestha to chair this session. I'd like to inform that the first speaker, Dr. Narayan Thapa, is not present, so we'll begin from the second speaker.
Without any delay, let's start our next session. The session will be the urolithiasis, and our first speaker is Dr. Manish Man Pradhan. He will be talking about importance of intrarenal temperature and pressure in retrograde intrarenal surgery.
He is a very dynamic young urologist working at TUTH hospital.
Thank you, sir, for the kind words. Good afternoon, everyone, respected chairpersons, faculties, and delegates present here. We've heard a lot of presentation about stones by now, and a lot of different techniques. What I want to talk about is the safety issue of the stone surgery, the importance of intrarenal surgery, intrarenal temperature and pressure during RIRS. I have nothing to disclose. So my learning objectives will be to define the safe physiological threshold for intrarenal pressure and intrarenal temperature, henceforth referred to as IRP and IRT. Second objective is to identify the potential complication associated with elevated IRP and IRT, to list the practical intraoperative strategies to maintain safe IRP and IRT levels, and finally, to recognize the interplay between the suction, irrigation, pressure, and temperature during RIRS. So let's go into the pressure part first. So why pressure and temperature is the matter? We all know RIRS is the most commonly performed surgery, especially in this part of the world, which is also known as the stone belt. And most of us are doing it day in and day out. So IRP and IRT are critical modifiable intraoperative variables because the uncontrolled level is directly linked to complications like infections, febrile UTI and urosepsis, traumatic complications such as foraneal rupture, bleeding and renal scarring, and the thermal complications such as tissue necrosis, stricture formation. So a proactive management is a key to patient safety. Let's look at the physiology and thresholds of the intrarenal pressure. The normal physical range varies between 0 to 20 centimeters of water. Whenever it exceeds that, there is different pathways, as you can see in the figure, where there is pilotubular reflux, pilovenous reflux, which risks us for sepsis, and when the pressure exceeds 80 centimeters of water, there is risk for pharyngeal rupture. So a balance between irrigation, the inflow, and the outflow ultimately defines the intrarenal pressure. So these are the consequences of elevated intrarenal pressure. First, the pyelorenal black flow. It causes translocation of bacteria, the endotoxin into the bloodstream. There is renal parenchymal damage, which leads to histological changes, urothelial denudation, tubular degradation, and focal scarring. The fluid absorption leads to electrolyte imbalance and volume overload. Especially, this matters in patients who already have cardiac and renal impairment. And there is, of course, the postoperative pain due to stretching of the renal capsule. So practically, what can we do to control the intrarenal pressure? If you look at this picture, our main aim is goal is to maintain the renal pressure below 40 centimeters of water. We can use a ureteral access sheath, which is well tolerated, so that the ratio between your scope, the access sheath and scope is 0.75. The gravity irrigation method is preferred rather than the pressurized pump. But honestly, let's have a show of hand here. How many of us still use pressure bag? Honestly, I do. 2. So 3, 4. Okay. So I guess we need to learn from you guys. We need to shift to gravity irrigation now. The working channel, as we know, if it's occupied, the flow is less. We need to keep the bladder empty so that the downstream resistance is less. And now we can also have real-time IRP monitoring. And of course, the use of suction seat, the fans, we have heard a lot about it. It helps in reduction of the intrarenal pressure. Now let's come to the thermal part. We have to remember the heat is generated when the light is absorbed, the laser light is absorbed by the irrigating fluid. And the study performed in animal model, what they have shown is that it takes 240 minutes when the heat is 43 degrees centigrade to cause a tissue damage. 240 minutes is, 4 hours? But it only takes 15 seconds when that temperature increases by 10, that is 53. So we have to remember the primary determinant of the intrarenal temperature, the laser power. Higher is hotter. Irrigating fluid, lower irrigation means hotter. And activation time of the laser, continuous activation means hotter. So what can we do? We can use a low power setting. In our past 10 plus years of using laser, we've never had to go beyond 12 or 15 watt. Yes, you can. If you have gadget, yes, you can, but it's really of no use. For us, in intrarenal surgery, we never go beyond 12, and in ureter, we never go beyond 10 watt energy. Irrigation fluid, now you have irrigation pumps there, 15 to 20 ml per minute. One of them have been displayed in the counter over here only. So yes, if you have the gadget, this is the recommended one to dissipate the heat. We have to teach our trainee to activate the laser intermittently. Studies have shown 4 to 5 seconds of intermittent activation to reduce the injury. But we all know when the youngsters, the newcomers get to press that laser, they would just keep pressing it for multiple minutes. So please ask them to stop. Of course, the ureteral access sheath improves circulating fluid, and it also helps in cooling, also improves vision when the dust are washed away. And studies have shown in a porcine model that if you use chilled irrigation solution, it is also effective. So there is the quadrifecta, the interplay of factors. The optimal RIRS requires balance between these 4 factors. That is suction, which improves, removes the debris and fragments. The irrigation, that provides visibility and cooling. The pressure must be controlled to avoid the reflux and damages that we discussed in our previous slide. And yes, the temperature must be managed. But the thing is, adjusting one parameter will affect the other. So the goal is to find that safe equilibrium. How to find that? Well, you have to do cases. That's where the experience comes. And of course, if you have a good mentor, it takes time, but you'll find that sweet spot of irrigation and pressure and your own laser power for optimal stone clearance with patient safety. So what are the future directions in technology? The real-time monitoring, sensor wire, and scope integrated into the scope itself to monitor the pressure are under development. But of course, it's a matter of how much cost does one have to bear for this kind of monetary cost for this kind of equipment. That's an issue. Automated system with a closed-loop system that adjusts the irrigation as well as suction based on live pressure data are there. Improved laser technology. Again, one of them is there in our stall, UROLASE, which detects the stone and only hits the stone, supposedly, and avoids the tissue damage. And of course, simulation training is essential for all the surgeons, especially the training to learn and practice before they can actually practice in the real patients. So to summarize, IRP and IRT are critical vital signs during RIRS. It's not just a byproduct. We need to know the threshold. For IRP is more than 40 centimeter water and temperature is more than 43 degrees centigrade. These are the danger zones. Control the intracranial pressure with use of gravity irrigation and occupying a channel with appropriate sized laser fiber. Control the temperature with using lower power energy, high flow of fluid, and intermittent activation of the laser. So finally, it all comes down to this quadrifecta, the balance of suction, irrigation, pressure, and temperature for the safe and most efficient outcome. Thank you.
Thank you, Dr. Manishman Pradhan, for a nice presentation. Since we are running out of time, the questions and answer sessions will be at the end of all presentations. So thank you very much. I will move on. I will call upon Dr. Ram Sagar Shah for his presentation on impact of intra-op calyceal selection for the stone-free rates.
Dr. Ram is professor at Novel Medical College. He is heading the department of urology there. Thank you.
Thank you, sir. Good afternoon, respected chairperson, seniors and colleagues, and my friends. First of all, I'd like to thank NOWS for giving me this opportunity to talk. And my topic is the impact of pelvic calyceal system anatomy on surgical outcome in PCNL. So we all know the most common patient we faced in OPD is renal stone. And its prevalence is 10 to 15% in the developed nation. And most common problem is the recurrence of the stone, which accounts for around 50% within 5 to 10 years. And it carries significant economic burden. So PCNL is the gold standard treatment for more than 2 centimeter stone. And these procedures are also done for stagnant calculi, large volume renal calculi, difficult lower pole stones, cystine nephrolithiasis, and anatomically abnormal kidneys. But the problem with complex calculi are higher incidence of residual stones. Multiple track is required, increased bleeding risks and multiple puncture, prolonged operative time, and higher complication rates. So we did this study, and in all cases we did preoperative CT and intraoperative air pyelogram is done. And these are done in 250 cases, and in almost all cases we do only air pyelogram. And if we find difficulty in selecting the calyx, then we use contrast. So this type of study is not done in South Asian population. So this study is on from July to December, 250 cases in Novel Medical College, and all cases has undergone mini PCNL. So why air? So air is used as there is no contrast-induced reaction. It is cost-effective, excellent negative contrast. So we can delineate posterior calyx easily as air moves up, and dynamic assessment during respiration, and superior delineation in non-dilated system. So anatomical parameters we measure is calyceal diameter is measured as widest diameter of the targeted calyx. Next, we take infundibular length. It is the distal point of the bottom of the calyx to the infundibulopelvic junction. Then we measure infundibulopelvic angle. It is the angle between the uretropelvic axis and infundibular axis. And then we measure the angle of the entry calyx to the stone present in the calyx. In our result, mean age was 41.2 years, and most of the patients were male, and 15% of the patients have previous PCNL, undergone previous PCNL. And most of the stone was easy stone that falls in guise 1, single or pelvic stone or single stone. And 80% of the patients have non or mild dilated system. So mostly I have chosen upper compound calyx for the assess in almost 149 cases out of 250. And air, almost always I have used air only. And I have found 92.4% stone-free rate with this, but the stone clearance was less, or residual stone was more common when there is increased calyceal diameter and calyx to stone angle was increased. With infundibular diameter, there was no significant, not significant with the stone-free rate. But Burma have significant stone free rate with the diameter of the infundibulum. But other study by Alvanesi and Binbe have not significant as our study. Burma may have these as the stone may be simple versus complex, or multiple crack may be required to free the stone. So stone distribution in our study was mostly in 110 cases, it was single pelvic with normal anatomy. And then other stagon also was there, and multiple calyceal involvement was also there. So once the stone is multiple or it involves multiple calyces, we all know the residual stone will be more. So clearance will be difficult. So in this study, we have taken upper compound calyx, and we found when we approach through the upper compound calyx, we are able to clear in 138 cases. That is 92.6% of the cases we have cleared from upper compound calyx. And very less, we have gone from lower compound calyx, only 5, and in 100% cases. So most of the approach was upper, and most of the stone was cleared. So comparison, other study by Burma and Aaron et al., they have chosen middle posterior calyx and followed by upper, but I have chosen upper posterior calyx mostly. So middle calyceal puncture is also equally effective as upper calyceal puncture. And in non or mild dilated cases, we are able to clear 94% of the stone, 94% cases stone free. With moderate dilatation, as the dilatation increases, the chances of stone clearance will be less, but that is not statistically significant. The number of calyces involved by the stone, if it is less, only 1 to 2 calyces is involved, then there is significant stone-free rate. So in 183 cases, there was no non-residual stone. But as the stone involvement calyces increases, or stagnant stone, the chances of residual stone will be there. Complication was 30.9%. Most of them was minor complication with fever, and clavitindo was in more than 2 in only 12.4% of the cases. So infundibular width, infundibular length, and IPA doesn't have any significance with the stone-free rate, but calyceal diameter, calyx to stone angle, and if number of calyces involved by the stone increases, it has significant with the stone-free rate. So in our study, we have taken 250 cases, and we have gone from upper calyx in 92.6% of the cases, followed by middle posterior calyx, and then Burma, Aaron, and others have also chosen middle and followed by upper calyceal. So we required multiple track in 33% of the cases to clear the stone, and stone free rate was 92.4%. But when we choose multiple track, operating time and analgesic requirement was increased, which is consistent with the Burma study. Overall complication was 30.9, and this is consistent with GIA have done a study in 2025. And minor blood transfusion, postoperative fever, and PCS injury was seen in 7.2% of the cases. So my conclusion is, calyx to stone angle is the strongest predictor for stone-free rate. Once the angle increases more than 80, it is higher chances of residual stone. Infundibulopelvic angle does not have effect on stone-free rate. Infundibular size or diameter does not predict the stone-free rate. But calyceal diameter, if it is more than 1.9 centimeter, it has chances of increased higher residual stone. Bleeding risks may be increased when there is narrow IPA angle and narrow infundibulum. There is higher chances of 25% chances of PCS injury. Thank you.
Thank you, Dr. Ram, for your nice study and nice presentation. I would like to invite Dr. Rikesh Zankarki. He is Associate Professor at BP Korala Institute of Health Science and heading the Urology Department. He will be delivering his talk on the hybrid approach, developing a patient-specific positional algorithm for PCNL at BP KHS.
Good afternoon. Topic is a patient-specific algorithm we want to create. Actually, after doing so many PCNL, prone PCNL, we recently wanted to change to supine and incorporate RIRS in our armamentariums. So for any consultant, it's they will perfect in one type of surgery, like prone or supine. But in staying in academic institute, we have to teach our resident also different mode of surgery. So background PCNL as a gold standard for stones, as we know, position affects access, safety, and outcomes. And evolution positioning meta-analysis done including 12 studies, almost 1,290, similar stone-free rates but lower operative time for supine PCNL, highlighting importance of supine positioning. So as we know, evolution of positioning, 1976, Fernstrom and Johansson, and 1987, Valdivia, modified supine, and ECIRS integrations. A significant improvement in flexible urotoscopy and intracorporeal lithotripsy increased the efficacy of retrograde intrarenal surgery. So decision flow, the rule of thumb. So patient safety, step one is patient safety. If the patient is at high risk for anesthesia in the prone position, obesity, and COPD. And step two, procedure complexity. If the stone requires a combined retrograde and antegrade approach, ECIRS default modified supine. Step three, surgical access. If multiple percutaneous tracks are needed for a massive staghorn calculus prone remains the traditional gold standard for workspace. So why need algorithm? Tool for task rather than using a one-size-fits-all approach. No universal consensus on positioning. Individualized patient-specific decision required. Position matters. Respiratory mechanics, hemodynamics, stability, access angle to posterior calyx, surgeon ergonomics, and intrarenal pressure. Here in this picture, you can see still with the obese patient now, so many doctors, they have already abandoned doing in prone, they are doing in supine easily. So prone position is excellent for exposure for our lumbar area. Direct access posterior calyx and upper poles facilitates multiple tracks and familiarity. Limitation, airway inaccessibility, reduced pulmonary compliance, increased intrarenal abdominal pressure, and repositioning required after cystoscopy. And so many people are involved to position the patient. Here in this picture, you can see in the prone position, it's more easy for making multiple tracks. In pediatric, we also still doing prone positional, supine positional. We found so much mobility of the kidney in initial period. And even in the scarred area, it's more easier for prone positional to do prone positional in postoperative cases. So in prone, upper pole access is, I find, more easy. Now we are doing supine. Maybe after a few more cases we'll be finding more easy, but I still find in upper pole, in prone position, easy for maneuver. So supine position, no repositioning needed, better airway control, lower intrarenal pressure, facilitates ECIRS. Limited upper pole access, narrow posterior surface, and learning curve. Here in this picture you can see 3 punks I have made, all going steep up towards up, and who are doing a lot of prone PCNL and is slightly moving towards supine is a little bit difficulty with this position. So here, position advocated by expert at BPCAS, Dr. Bipen. He came in our hospital to demonstrate supine PCNL. Another one, Dr. Dixit, who advocated true supine at our workshop. So we prefer during training supine is modified, split leg modified position. And continuing, we are still continuing with the supine PCNL. We have to consider the cardiopulmonary considerations and stone complexity, obesity, and positioning, and upper pole access. ECR indications and complication profile, intrarenal pressure, stone-free rates is all known to us. So ECIRS, recently we did ECIRS in retained digestion of almost 5 years. So position according to the stone location also matter. Flexible rotoscopy for supine RIS. Recently we did one ectopic, in ectopic kidney RIRS, and another one lower pole anterior calyx. The ectopic kidney RIRS is more easier than doing with laparoscopy or in laparoscopy guided PCNL. And multiple puncture is also easy in prone PCNL. Here is Dr. Monish demonstrating us RIRS in the workshop, and after we modified to supine PCNL. This is another case that we did, relocating of this. If you want to consider of the supine or prone PCNL, if the stone is in the lower pole calyx, you can relocate the stone to the upper pole calyx and do with the supine position also. So anesthetic consideration is there, spinal deformities, and there's one case patient with severe cardiac issues. Because we are more comfortable with prone than we did with prone with epidural anesthesia. Very complex stones in all calyxes were there, and we completely finished the stone with the 3 puncture and dilatation in this case. So developing an algorithm for positional in PCNL. After doing more than 2,000 cases of prone PCNL in last 5 years, the supine PCNL we have started from last February. Now we have almost done 102 cases. And RIR service started from November this year, 2025, and data is yet to be collected. So developing algorithm helps preoperative counseling and aesthetic planning, enhances safety, precision, and efficiency, addresses key concerns related to patients' comorbidities, stone burden, and allows surgeons to choose best individualized approach and teaching and learning MCH and MS program. So algorithm, severe cardiopulmonary compromise, supine, SS BMI, morbid obesity, BMI greater than 35 to 40 supine, excess stone complexity, complex staghorn or multiple track prone, excess ECIRS need ECIRS, supine, SS need for upper pole access, upper pole supracostal access required prone, surgeon expertise. These are my references. Thank you very much.
Thank you, Dr. Rikesh. By this, we would like to conclude this session. Now the floor is open for question and answer session.
there is no question, any comment from Dr. Uttam, Dr. Sabnis, Dr. Suman, any question otherwise?
So regarding the ear pyelogram, okay, I want to hear from the experts.
I was just talking to Dr. Sabnis also, so how frequently he monitors the internal pressure and temperature. There's a hype, and it actually needs some additional cost also, isn't it? So I don't think it has got a lot of practical utility for most of the stones cases for during RIRS. This is one thing. And second thing is, ear pyelogram, there is a concern for embolism. I don't know whether it happens or not. It just says there is a possibility. But how safe you are, I don't know. Maybe Dr. Sabnis can answer this question, ear pyelogram.
There is always discussion about ear pyelogram. There are some people who routinely do it, but there are many people who are not doing it. The objection of not using air for pyelogram is there is always chance of embolization. There are cases reported in the literature which are proved to be air embolization because of that. Secondly, that if it is a compact stone, the air also may not go. And the other thing is that why you want to put air is that the posterior calyx is filled up, and then you target the posterior calyx. But you don't know how much air to inject, and then the whole system is filled up. Then there is no benefit of identifying exactly the posterior calyx in a prone position which is coming up. And therefore, once you get used to it, it may not be required. But intrarenal pressure, I think he highlighted all the points very rightly, that intermittent use of laser is extremely important. And about the gravity irrigation, although we use pressure pump. Pressure pump has to be judiciously used. If you use only gravity, the flow may not be adequate, especially when you are using 7.5 scope with the laser fiber inside. Then your flow may not be adequate, and that is another reason why your temperature will increase. Because the flow has to be there, the whatever temperature, whatever fluid has to get washed out. Why in ureteric stone, there is an increased concern of the thulium fiber laser because of increased temperature, because there is no flow. In kidney, there is a flow, and therefore, if there is a flow, the temperature gets dissipated. If you don't use if you use only gravity, often the flow is not adequate. So we use pressure. You can use pathfinder, you can use anything, but a little bit of a pressure more than the gravity is required to keep the vision proper. And the other thing, what he highlighted, that is very important. In fact, we have a scope which has got temperature and a pressure monitor. The scope size increases. That is another deterrent factor apart from the cost. Is that if you use intermittent, most important is intermittent laser fragmentation. If you pause in between, maybe after every 10 seconds or so, the temperature drops down dramatically. So that is not a concern at all. So these are the factors for this.
Thank you, sir. There is no question. We would like to conclude this session by giving thanks to Dr. Manish, Dr. Ram, Dr. Rikesh for this nice presentation. Thank you.
Thank you, Chairpersons. I would like to request all the speakers of the session to come on stage for a group photograph. Thank you.
Thank you. Now I would like to the next session is reconstructive urology, and I would like to invite the chairperson of that session. I would like to invite Suman Chapagai, Rikesh Zangkarki, and Dr. Prabhat Chandra Biswas to the dais. Chairpersons, please.
So, thank you, Dr. Vaikuntha. So, this is a reconstructive urology session. So, we have a speaker, Dr. Li Zhao. He will be talking on the robotic ureteral reconstruction. He is from New York University, and he is a reconstructive surgeon. Can you play the slide, please? Since he is not physically here, so we will be presenting a video presentation of him, recorded presentation.
University, and I will be speaking about robotic ureteral reconstruction. To introduce myself, I am a reconstructive urologist in New York City, and I perform some 700 reconstructive cases a year. Because of the location of my institution and the technology available to me, most of what I will do and show is robotic. However, the principles that I will illustrate are applicable for laparoscopic and open surgery as well. I want to propose a paradigm for ureteral reconstruction that involves precise location of stricture, preservation of the blood supply with minimal ureteral dissection and avoiding of transecting the ureter, because the blood supply of the ureter flows longitudinally, and the use of grafts and flaps to restore the lumen. For unilateral upper tract reconstruction, this is the position. It allows access to the kidney, bladder, and ureter from one position. If there's a nephrostomy tube, I'll leave that exposed, and I'm able to ureteral reconstruction. To introduce myself, I am a reconstructive urologist in New York City, and I perform some 700 reconstructive cases a year. Because of the location of my institution and the technology available to me, most of what I will do and show is robotic. However, the principles that I will illustrate are applicable for laparoscopic and open surgery as well. I want to propose a paradigm for ureteral reconstruction that involves precise location of stricture, preservation of the blood supply with minimal ureteral dissection and avoiding of transecting the ureter, because the blood supply of the ureter flows longitudinally, and the use of grafts and flaps to restore the lumen. For unilateral upper tract reconstruction, this is the position. It allows access to the kidney, bladder, and ureter from one position. If there's a nephrostomy tube, I'll leave that exposed, and I'm able to perform antegrade and retrograde endoscopy, which will be important. In terms of what I will be showing, if the stricture is close to either end, we'll typically perform a direct connection, meaning a pyeloplasty or a reimplant, and reconnect that, and then augment the other side with buccal graft or appendix. Long Ayres route lumen means ileoureteral replacement generally, and then failure of that means auto transplant. Here's a video illustrating how to do pyeloplasty. In this particular case, I'm doing a single port robotic approach, meaning that we're accessing through a supine position. And I usually put a ureteroscope up the ureter to help localize stricture. For pyeloplasties, you don't have to do this, of course. It's pretty easy to tell where things are, but I generally do endoscopy as a principle for just by doing essentially the same thing for every case so that I know exactly the location. I've gone away from transecting the ureter for pyeloplasties. Instead, I will do a Y to V flap and avoid transecting the ureter. The principal reason for that is I found from revision pyeloplasties that many strictures occur because of transecting the ureter has made the proximal ureter ischemic. And so to preserve the blood supply to the ureter that is running longitudinally, I don't transect anymore, and I just do a flat-based pyeloplasty to bring the two ends together. And here's the place for the stent, and you can see me suturing the rest of it. This is a barb suture that I'm using to help hold the tension, and just closing both sides of the flap. This way, the ureter is not transected, and in this particular case, there is a crossing vessel, but we have repositioned the UPJ lower and posterior to the crossing vessel so that it's no longer in contact. And this serves to correct the problem with the crossing vessel just as well as transposing it to the other side. And surgery is just over an hour. The appendix is something that I use, especially on the right side. The key thing is to always have a backup because sometimes the appendix is obliterated, as in this case. This essentially is pretty high. Here's a video of a patient who had a ileal conduit, had multiple bowel resections, had a functionally solitary right kidney that was strictured because of radiation. And in this case, the stricture was quite long. I am dissecting and incising upon the ureter, going all the way up. Here you can see the stricture, and just following it with a wire over there. And once we have the ureter spatulated, this is some 7 or 8 centimeters long. I was left with not many choices because the patient did not have a lot of bowel left. And so here is the taking the appendix off the cecum. I cut the staple line, and then here is the anti-mesenteric side. And then here is the cecum moving down, and then I'm suturing the appendix as an onlay. One reason I like to use the appendix as a flap that's as an onlay as opposed to interposition is that now I have one long anastomosis, and so the probability of it having a stricture is lower than if I interpose the appendix and I'm left with 2 small circular anastomoses. I think a longitudinal anastomosis is much less likely to narrow than a circular anastomosis, and that's why I do an onlay in this case. Closure of this. Now, buccal mucosa is something that I'm fairly well known for. This is our series from 3 institutions from roughly 160 cases over 10 years with success rates about 90%. Generally used as an onlay. So buccal graft and reimplant could be placed together. There are times when you find strictures that occur in two separate locations. In that setting, you don't want to transect the ureter at two places. And instead of doing an ileoureter substitution, I will perform a non-transecting side-to-side ureter reimplant and a buccal mucosa graft at the same time. This allows us to preserve the longitudinal blood supply of the ureter and still restore the lumen. So here in this video, doing a retroperitoneal approach. This could be done open retroperitoneal through a Gibson incision, or can be performed laparoscopically through a transperitoneal septal-reflecting colon. The surgery starts by dissecting down towards the pelvis. Here the ureter lies above the iliac vessels, and I'm moving the dissection upward. You can see it's tracing the ureter, and the stricture is located right here. I'm making an incision. Prior to doing the incision, I inserted a wire into the ureter just so I could establish a lumen. And then I used a cystoscope to show me where the bladder is so I could put a suture on the appropriate counter spot on the bladder. And here is that suture. And now I'm going to do a side-to-side anastomosis between the bladder and the ureter. And I just pull the two together, and then the side of the ureter goes to the side of the bladder. And as I complete this anastomosis, I had suspected that the patient had a stricture more proximal to this, but on imaging, I wasn't totally certain. And I usually perform ureteroscopy in these settings just so that I know that when I'm done the OR, I can put the ureteroscope up and I have a complete lumen. Well, here's the completion of the reimplant, and then I'm going to pass a scope upward, and so you can see the scope going along the ureter, and as I go up, I don't get to the renal pelvis. I actually get stuck here at a mid-ureteral stricture, and so I'm going to incise that mid-ureteral stricture for as long as where the stricture is. This patient had kidney stones as the source of his multiple strictures in his ureter. And now here's for the incision. And once I'm able to pass the scope in, I know that the lumen is bigger. I want to check to make sure there's no problem going up and down. And at this point, I'm going to suture a graft in. The measurement turns out to be about 3 centimeters or so. And then I'm going to suture the graft onto the ureter. Every graft requires some support to allow it to perfuse. And so here is the graft being sutured in. I suture one side, and then I will quilt the graft eventually onto the psoas muscle to allow the mucosa to take. So here's one side, here's the other side. And again, this could definitely be done open. It's just that the video of open surgery for me is not quite as good. And or it could be done laparoscopically. You could also use other tissue to support the graft. I'm using the psoas here, but if you're doing transperitoneal, then what I've commonly used is the omentum to suture onto the graft to make it a little bit easier. And so here is the finished product. So to summarize, ureter reconstruction, the goal is to restore open lumen and to keep all viable ureter without burning any bridges. The key differences from standard reconstruction that I push for is to use of grafts and flaps for long strictures in a small lumen. Thank you so much for your attention.
I welcome our next speaker, Dr. Prakash Chetri, the consultant urologist from Pokhara, the talk on female urethral strictures. I welcome Dr. Prakash Chetri.
Good afternoon, respected chairpersons, and national and international faculties, delegates, and dear colleagues. At the outset, I would like to thank NAUS for offering me this platform to share my experiences on female urethral stricture. And this pattern of male urethral strictures are quite familiar to us, but they don't seem to be reflected in females. So this is the story of a 59-year female who presented with voiding and storage symptoms for the last 4 years. And she used to present with acute retention occasionally, for which she needed to have catheterization for a short period. And she was under regular urethral dilatations to weekly interval for 2 years. The flow used to improve immediately after dilatation and weakened gradually. Cystoscopies were done in multiple centers and were labeled as meatal stenosis, bladder stenosis, a few bladder trabeculations. The post-void residual urine was high, and there was a mild and thickened bladder wall. This is the uroflowmetry showing flattened T2 graph and with a Qmax of 15 ml per second. This is the voiding cystourethrogram of the same patient showing mid-urethral stricture with pre-stenotic dilatations. And there are a few diverticulars on voiding. Cystourethoscopy was performed, and it showed mid-urethral stricture narrowing of the urethral lumen. So this was the case of mid-urethral strictures, and she underwent anterior buccal mucosal graft urethroplasty. The plain anus was installed over the dorsal region for hydrodissection, and inverted U-shape suprameatal incision was made from 9 o'clock to 3 o'clock position. Dorsal plane was created between the clitoral bodies and the urethra. The urethra was incised longitudinally, and after each installation, after incision, the state suture were placed, and the urethra was palpated up to the pubic bone, and it marks the point of proximal incision. This is the incision of the dorsal urethra, and the harvested buccal mucosal graft was placed over the urethra with this mucosal surface towards the lumen, and 3 rows of quilting suture was done, and the graft was sutured over the urethra with incorporating the mucosa and perimeatal, lateral perimeatal tissue. And at the end, silicone catheter was placed. So the patient was discharged on the second postoperative day, and catheter was removed after 2 weeks, and this shows the postoperative uroflowmetry of the same patient. The Qmax after on this postoperative uroflowmetry was 44. So we had 20 cases in the last 5 years, ranging from 29 to 66 years, and most of the cases were idiopathic, and 4 had catheterization, history of catheterization, and 1 patient had history of radiotherapy for the cervical cancer. The preoperative Qmax was 12 with a standard deviation of 6. All the patients underwent anterior buccal mucosal graft urethroplasty, and the postoperative Qmax was 35 with a standard deviation of 6. And 1 patient had restricture. This was the same patient who had history of radiotherapy, and 2 patients had incontinence postoperative. So coming to the discussion, female urethral stricture is a rare disease, and this stricture accounts only for the 4 to 13% of the causes of the bladder outlet obstruction in female. The delusion in female urethral stricture starts from the definition. some advocates it as it's difficult to negotiate a 15 French cystoscope, whereas some define it as difficulty in passing a 14 French instrument. And whatever may be the definition, it's the scarring of the urothelium with or without spongiofibrosis causing narrowing of the urethral lumen. Most of the cases are idiopathic, and other causes may be iatrogenic, inflammatory, traumatic. The clinical presentation usually, these patients present with lower urinary tract symptoms with a history of intermittent catheterization. And there is often a significant delay in the diagnosis of this stricture in females with the mean delay of almost up to 12 years. They are usually underdiagnosed, and it requires high index of clinical suspicion. Physical examination is mandatory, and the initial workup starts with ultrasounds for post-word residual urine. Uroflowmetry has no specific cutoff value and patterns, and usually the Qmax will be less than 15 ml per second. These are the few urethrometry patterns of the same patient in different scenarios and of different patients. The calibration is usually controversial. And this study concludes that a good caliber of the urethra, even 14 French, is not sufficient enough to rule out significant obstructions due to female urethral stricture. Cystourethoscopy. During cystourethoscopy, not all the patients have the similar finding that I have mentioned in my index case. And in this study, among 16 patients, only 1/4 of the cases had obvious narrowing of the urethral lumen with inability to negotiate the cystoscope, while rest of the cases, majority of the cases, the cystoscope could be negotiated. Voiding cystoscopy is the most important investigation in female urethral stricture. It can be done in anterior posterior view, and it provides information on the location and the length of the stricture. The narrowing of the urethra with pre-stenotic dilatation, mimicking wine glass image, is the most consistent finding in female urethral stricture. These are the various Visusi images in such patients. Urodynamic study is reserved for moderate to severe tribulations on cystoscopy, and it shows high pressure, low flow pattern. And with combination of imaging and the video urodynamic study, this maximizes the data that urodynamic study offers. And pelvic MRI is usually helpful in some cases, particularly if there is suspicion of pelvic organ prolapse or additional pathologies such as malignancy. The management includes minimal invasive techniques and, of course, open surgery. It's quite acceptable to start with urethral dilatation, at it has patency rate up to 51%, but repeated urethral dilatation is unlikely to be curative because it is associated with trauma leading to inflammation, bleeding, extravasation, and augmenting the periurethral fibrosis at the same time maintaining a good caliber. Urethrotomy is of theoretical value, and none of the study has proven its role. Meatoplasty is reserved for meatal stenosis, which is very extremely rare. The definitive management includes urethroplasty, and it has high success rate of 80 to 100%, and it is favored for failed minimal invasive treatments or as a first-line treatment. And various flaps and graft are incorporated. The flaps including the vaginal and labial wall, and a multitude of graft are incorporated. And the approaches can be anterior or posterior. In anterior approaches, there is increased vasculature and support for the graft. And in the same time, there is increased blood loss, causing the field to be very messy. It's reserved those patients which needs for future anti-incontinence procedure. And it has disadvantages of injury to the clitoris or the neurovascular bundle, causing sexual dysfunction. And there is a risk of incontinence and damage to the pubourethral ligament and striated sphincter. On contrast, the posterior or the ventral approach requires minimal urethral dissection, and it is easier to use flaps. And at the same time, it has risk of causing hypospadic urethra and the risk of uretrovaginal fistula. On recent EU guidelines, it has a strong recommendation of performing uroflowmetry, post-residual urine, and voiding cystourethrogram for these patients. And it strongly recommends urethroplasty in women with the second recurrence of stricture and who cannot perform this intermittent self-catheter dilatations or with definitive treatment. The technique of urethroplasty should be determined by the surgeon's experience, availability, and quality of the graft material and quality of the ventral versus dorsal urethra, which is anterior or dorsal urethra. So, to conclude, it's very difficult to diagnose. The challenge remains in the diagnosis of the female urethral stricture, and it requires high index of clinical suspicion. And voiding cystourethroplasty is the most consistent finding, and the definitive treatment is urethroplasty. Thank you.
Thank you, Dr. Prakash Chetri. We'll take a question at the end. I'd like to welcome Dr. Sudeep Casey, and the topic management of anterior urethral stricture current treatment options.
Good afternoon, respected chairpersons, our professors, and all the friends and dignitaries present there. Thank you, NAUS and UROCON, for giving me the opportunity to present the topic of my interest, but it's quite a big topic, so 7 minutes will be difficult for me to cover. So today I'll be talking about some of the treatment options for anterior urethral strictures. We know that we divide urethra into posterior and anterior urethra. More than 90% of the strictures are in the anterior urethra. That starts from meatus, navicularis fossa, which is generally said as distal ureteric strictures, and there is a pendular or penile urethral stricture, and there is the bulbar urethral stricture. So most common of which is the bulbar urethral stricture, followed by penile and the distal urethral stricture. So the different plans, all individualized. It is not that we follow the strict guidelines and we have to do the same treatment for all types of strictures. So it's all individualized, and Dr. Mundi sir has said that it is not necessary that we have to treat all the strictures. It depends upon the complications brought about by the strictures. Complication, it means by all these back pressure changes or all these infections and secondary stone formations, or if the person is bothersome, if it's disturbing his life, then we have to go for the treatment of the strictures. Now briefly I'll go about different sections like distal fossa navicularis and the meatus strictures. It is most commonly caused by the lichen sclerosis, then iatrogenic, and also failed hypospadias surgery. There are various ways like dilatation, and the dilatation it has very poor outcome. In various studies that showed that like 85% of the time it has a high recurrence rate, and there is something like simple and plastic meatotomy. It is somehow better than that. In the simple meatotomy, just the ventral incision is given and we wide open the meatus, and in the plastic they say in which even the dorsal incision is given in the urethra meatal. meatus, and this extended meatotomy, where there's a little bit more of the extension is given in the ventral aspect of the urethra on the distal part. So cosmetically, extended meatotomy is not that good, but they have very good results. More than 87% success rate with this with the extended meatotomies. There are other reconstructive procedures for the distal urethral strictures like Jordan's technique and Armerska's, and he has modified this Jordan's technique, and the results are very good. They have mentioned in their article there are 100% success rate with their procedures, and also there are good results with the grafts and the flaps. But generally, we know that in the lichen illustrative, local skin is not used, so buccal or skin distal away from the penile skin is used for the grafts. Coming to the pendular urethral stricture, the commonest cause of which is I told you, the failed hypospadias repair and idiopathic causes lichen sclerosis. Similarly, there are different ways, like we can go for urethral dilatation, DVIU, or also now, there are like injectable agents, and their catheter, balloon catheter, they are coated with paclitaxel. And because of the high recurrence rate, we have been trying that how we can have good result of these different procedures. So they have been trying with catheterization for prolonged duration, and we have been doing self-independent catheterization. There are injectable agents like mitomycin C, triamcinolone, and oral colchicines, and balloon paclitaxel coated balloon dilators are there. And also in certain conditions, we can go for this temporary or permanent stent placements. Triamcinolone or this submucosal mitomycin C or colchicine, they really have very good result. More than 80% of the time they are useful. The different studies they have shown that even with the use of these paclitaxel coated urethral balloon dilators, and they said that at 6 months the rate of anatomic success defined by the ability to pass the flexible cystoscope was 75% when it was compared with 27% of the DVIU alone. So it showed a good result. Then there are surgical reconstructions like Johnson's twisted repair, Ossopaz techniques, Kulkunisov's technique. So I'll not go with the surgical procedures which we have been doing, and they have really very good result compared to all other procedures or techniques what we have been talking. Coming to the bulbar urethral strictures, the most common of which is the idiopathic, followed by transurethral resection. My following colleague will be talking on the TUR-related strictures. And there are like minimally invasive techniques, like as I previously told, in local injections with this triamcinolone and botulinum toxins. They have also significant significant good result with their injection. Yes, I'll not go through these. When we talk about the bulbar urethral stricture, there are like anastomotic techniques, like primarily we exercise and we do end-to-end anastomosis, and a better technique is like vessel sparing technique, in which we try to preserve this bulbar artery, and we try to save that artery for the vascularity and for the better outcome. Yes, we try to preserve the vessel, and there is like giving the incision longitudinally and suturing them transversely, and you can microlyxurethroplasty. Then there's another very nice is the non-transecting anastomic bulbar urethroplasties, where we don't transect the corpus spongiosum. Just we excise the scar and we do anastomosis. I'll show the pictures. Let's go to this bulbar. Okay. So one is a mucosal sparing non-transected anastomotic MSANT urethroplasty. Another is the mucosal anastomotic non-transecting augmented urethroplasty. In this mucosal sparing, where we go through we mobilize the urethra and we go dorsal. We give the dorsal incision in the urethra, and we anastomose the urethra, the mucosa of the urethra, to make the base or the base of the plate quite wide open, and we augment with the this BMG graft or any graft. BMG is the best one, so we kept there, and we do here. We don't incise or resect the urothelium. Whereas in this mucosal anastomotic urethroplasty, we excise the mucosa, the scar tissue, along with the scar in the corpus, but we don't transect the corpus spongiosum, and we approximate these two ends of the mucosa, and we widen the plate, and we close it. And this is a ventral approach. So in this case, the ventral only BMG urethroplasty is done. So I would like to conclude that intervention should be tailored to individualized case, as I told previously, and success is defined not by just the patency of the lumen, but by quality of life, sexual health, and morbidities, and the cosmesis as well, cosmesis of the glands. Yes, just briefly, I would like to tell about this mucocell. It is a engineered tissue, like tissue engineering, where a small biopsy is taken from the cheek, and it is manufactured in a company, and then after 2 weeks or 3 weeks, it is taken, and a prepared size is incised, and it is grafted in the same way as it has been done in other techniques like Kulkarni's technique or any other techniques. And it has also a very good success rate of around 67% 1 year, and in about 2 years, it has a success rate of about 58%. I've been thinking that we don't have so many of cases in my center, but at least in 5 years, we have done adequate. I don't do hypospecialty surgery because of the fail rate previously, but I'm happy, and patients are happy with these urethroplasties. So I've done few of the cases with somehow good results, and that's also. Thank you. There was a small video. I think it's not playing. No, it's okay. It's okay, sir.
Thank you, Dr. Sudeep, for your excellent presentation. Now we'll have another presentation by Professor Kusal Karki. So he's going to talk about simultaneous urethroplasty and TURP in the management of post-TURP urethral stricture.
Respected faculty, chairpersons, esteemed faculty members, and dear colleagues, good afternoon. So it's my privilege and pride to present here at NOW's UROCON 11th UROCON conference, and I'm very thankful for the organizing committee for giving me this opportunity. So today we are talking about transurethral TURP. So I'll be covering about the complications of TURP, and about the simultaneous management of urethral stricture and the BPH, and what lessons we have learned in my clinical practice. So if you go towards some prefix used in the medical dictionary, then something that is done with an abnormal opening, like then we call it a transthoracic or transabdominal kind of thing. But same thing, if you go through the natural orifice, we will call it a per rectal or per abdominal, per oral approach. But it is not used in the similar way, because we call it a PCNL, not the TCNL. So similarly, it's not the PURP, but it is a TURP. So if you look at the pattern of management of BPH, then still at 2026, it's a TURP, more than 50% or almost 50% of cases done by TURP, as shown in this literature in European journal. So another point I want to highlight is that in the best of the done TURP, it's about 40 to 50% of glands is resected. So half of the gland usually we left there. And there was a study, is it really necessary to take out all the glands during the TURP? It was published in European Urology. Among the many complications, the most feared one is the urethral strictures, and it is around 4% in monopolar, little in this 2.1 in this bipolar, and HOLEP, they still have 1.5%. The reasons given for this is the thermal injury, that is stray current in the TURP, the use of large size sheath, longer catheterization time, and this prolonged surgical time are the cause for the urethral stricture. So it's a technically demanding art that requires the mastery. So initial stage of the training, you struggle with the speed of resections, you fight with more complications, and the plateau of performance usually reach at 80 plus cases. And at the initial stage, the problem phases are the bleeding control, the tissue plane identification, and the smooth loop movement. And I asked ChatGPT to give me some pictures reflecting this scenario, and this was the picture given by ChatGPT. So in my clinical practice, I came across these 4 cases which were undergone TURP at various period of time, and they had now present with the urethral stricture. Most of them were proximal bulbar, and one was the distal bulbar stricture. But another interesting thing was that they had sizable prostate gland. So we have decided to manage both the urethroplasty as well as resection of the prostate in the same sitting. So we put patient in the lithotomy position, and we inspect this, put the guide wire through the ureteroscope, and then we explore the stricture portion of the urethra through the perineal incision. We open up the strictural portion and calibrated the proximal and the distal segment of the urethra. Then we put TURP sheath, and we did TURP in the standard fashion. After the complete TURP, now there was chance for doing urethroplasty, and another team harvested the buccal mucosa, and we did ventral only urethroplasty in 3 of the cases, and in 1 case we did excision and primary anastomosis. So what different was there at after doing TURP? Now basically we irrigate that thing with the normal saline, but in this case now we have to do urethroplasty. So after putting the graft, before closing this urethra, I make sure that there is no any clot left. Again, I clean this bladder with the ELIC. Then another thing was we couldn't put the 3-way catheter here. So I had to put 16 French catheter because I don't want to put this stress to this new graft. And irrigation was done through the suprapubic catheter, or you can put 3-way catheter in suprapubic region also. The post-operative period was uneventful, except there was incontinence in the patient, but it was taken care after a few months, and there was stress incontinence to the patient, and it was well managed with the beta-3 agonist. Should we be worried about the incontinence? So if you look at the anatomy of the urethral external sphincter, then it is omega sept. That means we have got the defect at the ventral portion. So we have, if you do the dorsal approach, then we have to incise this whole thickness of the urethra. Then you have to put the graft. So in that process, you may injure the urethral sphincter. That's why we usually prefer to do ventral approach, so that only you can just incise the mucosa, and then you can put the graft, and you do very minimal damage to this urethra sphincter. And it is very easy to, accessible surgically to approach the ventral portion than the dorsal portion. So this is the small video, and to it's not working. Sorry. Yeah? So it didn't play. So is there any other options? Like we have got other option. We can do anti-grade TURP, or you can do only urethroplasty, because we don't know if that residual amount of tissue is really causing bladder outlet obstruction. Or you can do salvage procedure like perineal ureterostomy, or you can put the patient on suprapubic catheter. So what about antegrade urethroplasty? If door is closed, then you have to open the windows. So through the opening in the bladder, you can do antegrade TURP like so in this paper. So if you look at the literature review, then people had done TURP through this artificial opening since 1976, but at that time it was done to reduce the stricture rate, and it worked quite well at that time. So at the modern time, as the case series published in Journal of Urology, they have done HOLEP after, in this kind of situation. They have opened this urethra and done the HOLEP and did the ventral-only urethroplasty at the same sitting. So to conclude my presentation, simultaneous TURP and urethroplasty is quite feasible. I don't have any issue with the terminology used, but the reason why I'm presenting this case is at the initial stage of this learning career, we have become very over-enthusiastic, and there is increased risk of causing trauma to the urethra, and we give stricture. And at the same time, we tend to leave quite a good amount of prostate behind. So we should always remember that the patient goes through this morbidity, and we have to manage this kind of cases later on. Thank you.
Thank you, Dr. Kushal, for your excellent presentation. So any questions and comments? Any comments, please?
Greetings from Bangladesh. I'm Dr. Maria, urologist from Dhaka. My thesis was actually on female urethral stricture, so I have a question for Dr. Prakash. So in your personal experience, which patients would you offer BMG urethroplasty as the first-line treatment? And another question, in cases where the buccal mucosa is unhealthy or unavailable, do you have any other options of harvesting, like vaginal mucosa?
So thank you for the question. In all cases, I have done anterior urethroplasty with the buccal mucosal graft. So what was the first question? Yeah. I think first, most of the cases which came to me, they have long duration history, and they almost, except one, in all the cases, they have undergone some sort of dilatations. So I did urethroplasty, and when the patient comes to me for the first time, I would like to prefer urethroplasty definitive treatment than undergoing dilatations. And if all the cases had this fairly reasonable buccal mucosa, that's why I've done buccal mucosal graft. And if there had been a problem with the buccal mucosa, then I would have gone for the flaps as well. But I have no experience on these flaps. I have done only all the cases buccal mucosal graft with anterior approach. Thank you.
Any other questions and comments? Dr.
Prakash, you said in your series there are 3 patients who had incontinence.
2.
Yes. So how did you manage those cases?
Okay. In most of the conferences that I've gone in UROCON, almost all of the surgeons used to tell that none of the patients had incontinence. So I think I was over enthusiastic. So what I think that I have gone over more incision over the bladder. Retrospectively, I think so. That's why I had incontinence in one of the patients. I feel so. In that patient, post-operatively, I did urodynamic study, and it came out to be normal. There was no overactivity. So I gave her, I gave her a milabegron, agonist. But at the end of 3 months, she became continent. I don't know what's the reason she became continent. But the next case, She is quite reluctant to go urodynamic study, and she was quite happy with with non-bothersome incontinence that rather than the retention that she used to have previously. So currently she is under mirabegron as well, and she is quite happy.
The last presentation, the stricture urethra with BPH. The problem is whether you want to treat simultaneously both the conditions or not. I don't think we are sure, because bladder outlet obstruction, how much is contributed by the prostate and how much is contributed by the stricture, that we are not sure. So I think it should be a sequential treatment. First you take care of the stricture and then see if the symptom persists, then you go for prostate, maybe medical therapy can help. So why
yes,
shall
sir.
I go for simultaneous?
So I mentioned one of the option is that. So why did simultaneously? Because these are the old people, and once you have done urethroplasty, whatever best you do, you don't make 28 French urethra. It will be 20 or 24 French or 18 French. So again, going to URP from that, if in the future, if it happened, then it would be a nightmare, and you are again disturbing that your surgery. And at that time, your option will be going from anti-gate or other things. So if I can manage at this time, then I think I can present this future complication that will that might happen. We cannot ignore that it won't happen.
What is the incidence of bladder neck contracture in your hand?
Bladder neck contracture, sir.
Always TURP, bladder neck contracture is one
So
of the
I think,
complications.
sir,
What is the incidence in your hand? So because you are anticipating that these patients may not come back, so I should treat him. But on the other hand, the complications of TURP is also there.
So I think, so in my experience, sir, in the good size gland, so if you do decent TURP, then the bladder neck contracture is very less. If you are doing small size gland, 30 gram or 40 gram, basically I always do in this small size, I do bladder neck incision and my bladder neck contracture is very less. But in this large size gland, I don't think there is that much common.
Sir, I have an comment and query to Professor Kushan. How was the gland volume in your series?
So I mentioned there it's highest 66 gram to 45 grams.
So what type of energy you used? All are the same monopolar or?
It's all of them are bipolar.
Do you think that the energy is very crucial as you are going to uretroplasty also? Or, so do you think that it interferes
regarding urethral stricture rate, because of stray current and current leak, there can be a bit of increased rate in monopolar. It's 3.8 that is mentioned in the literature, and a little bit of less in, but it is not the only one factor we can consider, because there are other factors like how much you are doing, how much prolonged catheter you keep it. So there are multiple factors that affect this urethral stricture rate.
Thank you. We are expecting that, and expecting is the good result, and wish you, Professor Prashad.
Thank you. Sir.
Any questions regarding any topic? Those are presented. The 5 topic was there. If we don't have any queries, Professor Sabnis, sir, any comment?
So if there are no questions or comments, so we conclude this session. Thank you very much.
Thank you all the chairpersons. Now I'd like to request Dr. result thank you. So wait for a little while, please be patient. We'll be announcing few results, I think. So, and lastly, vote of thanks. Then we'll have a prize from the medical representatives. Lucky draw. So, welcome everybody inside the hall. Whoever is not inside the hall will not get the lucky draw prize. So first, the lucky draw from DJPL. सुमन दाइ के अरे मनिष दाइ के गर्ने त अब कति टाइम लाग्छ के गर्नु नाम भनेपछि दिएर छोडिदिनुहुन्छ नि जसले पाउँछ त्यसैले दिएर हुन्छ अनि So, the lucky draw winner is Dr. Saman Faruqi. Absent? Dr. Manish Pandey. Manish Dai. Prize त दिन आउनु दिने मान्छे छैन So I request Dr. Manish to hand over the prize. Congratulations, Dr. Manish. So the winner is Prajwal Paudel. No. Is he here? Prajwal Paudel. Uspal Bajracharya. Uspal. La. Prajwal guy. Prajwal Paudel. Congratulations. One of the lucky prize winner from Sun Pharma. So the next one is Turba Adhikari. He just left. Oh, म जान्छु भनेर जानुभयो हात मिलाएर त्यही भएर अजय महर्जन कुशल कार्की All of you be seated. We have few more prizes to come, and we'll have lastly the announcement of the winners of the resident award session and young urology award session. Thank you, Sun Pharma. Now the lucky draw from Divine Healthcare. Oh, it's for the Max Flow lucky draw, lucky prize. He has already left. Prabodh Regmi, but he has already gone. Dr. Sriya Karmacharya. Dr. Sriya. Max Flow Lucky Prize winner. Now the second lucky draw is for the Mirabeg. The lucky draw prize for Mirabeg goes to Silas Morgan. He's not here, we are picking another one. Dr. Suman Sapagai. Mirabeg lucky draw prize winner. The Rapid Flow lucky draw prize winner goes to Dr. Neeraj Maske. No, he's not here. Since he's not here, we'll pick up another one. Dr. Trinetra Karna. So he's also not here, so we'll pick up another one. Dr. Arun Sa. He's also not here, so we'll pick up another one. Oh my God, she is the another prize winner, Dr. Sriya Karmachare. Chani, ai bhakar liएर गएको थियो तपाईले दिनुभयो हो त हैन त्यो अर्कै प्राइज हो नि त्यो आइको त आइको अर्कै कम्पनी हो नि त डिफरेन्ट कम्पनी हो नि सो कङ्ग्रेचुलेसन्स रिया गुड लक डेज
थ्यांक यू सो मच सर थ्यांक यू सर
all the residents to be present inside the hall as we are about to announce the awards for different sessions that happened today. So just wait for a while. To welcome Dr. Suman Chapagai, General Secretary of NAUS.
For Young Urology Award, Resident Award announcement and formal closing.
I would like to request Dr. Suman Chapagai, General Secretary of NAUS, for announcement of different awards and also the closing of the today's program.
Thank you, Dr. Vaikuntha. So, finally, we came to the concluding part of the conference, the UROCON 2026. I would like to thank all the distinguished delegates, all the international and national faculties, and I also would like to thank you for patient hearing and participation till the last of this conference. Your participation has made this conference successful. Thank you so much. And I would especially like to thank my friend Dr. Manish. Please, I would like to ask him to come in the front, for being with me all the time during the conference and making this conference successful. So, and also Dr. Sujit and Dr. Vaikuntha for their tireless effort during the conference. Actually, they made this conference successful. So, and also I would like to thank our local chairman, Dr. Dhruva Adhikari, sir, thank you so much. And Dr. Prakash, thank you so much for our local chair, Dr. Prakash, for the immense work to make this conference successful. And I would like to announce the result of our Young Urologist Award and the Best Residents Award. So, Young Urologist. So, we have 3 categories of awards that we are giving for the young urologist. The first one is Prem Gewali, sir, Endourology, the Professor Prem Gewali Endourology Award, which is awarded this time to Dr. Bipin Guragai. He scored the highest among the judges. So similarly, Professor C.S. Agrawal Travel Grant Award, it goes to Dr. Suman Adhikari. So he scored the highest marks, he secured highest to secure this award. Congratulations, Dr. Suman. And since this year we have no female urology papers, so we are keeping it as a due, and we will be awarding this next year. So we have not announced Professor A.D. Bhatta sir Female Urology Award this year. So it will be due for next year, and we will select there by encouraging the papers for the female urology section. Now, as per the Best Residents Award, it is based on the papers they have presented and our judges who have given them score. And the first place goes to Dr. Ishwar Paudel. And the second award is Dr. Umesh Pradhan. And third award is, they have a tied number, so we have 2 third award winners this time. That's Dr. Suresh Thapa and Subodh Ghimire, Dr. Subodh Ghimire. Congratulations to all of you for securing this award. Yes, sir. Okay. Okay. So Dr. Bipin Guragai and Dr. Suman Adhikari are from Tribhuvan University Teaching Hospital for the Young Urologist Award. The Prem Gewali Endourology Award goes to Bipin Guragai from TUTH. And C.S. Agrawal Travel Grant Award is also for Dr. Suman Adhikari from Tribhuvan University Teaching Hospital. And the residents, Ishwar Paudel is from the National Academy of Health Sciences and National Academy of Medical Sciences. Dr. Umesh Pradhan is from Tribhuvan University Teaching Hospital. And Dr. Suresh Thapa is from Tribhuvan University Teaching Hospital. And Dr. Subodh Ghimire from Nepal Medicity Hospital. Thank you. So, okay, so I think this concludes our closing ceremony. Thank you once again for your patient hearing, and thank you once again our trade partners, and thank you for our event manager Harishyamji for organizing, for helping us organizing this event. Thank you very much. This is the formal, and I declare this as a formal conclusion of this UROCON 2026. And we have a next year conference in Kathmandu, which is in combination with Urological Association of Asia. So it is NOUS UAA Summit that is going to happen in 2027 in Kathmandu. So I would like to meet you again there. Thank you very much.